Good morning, ladies and gentlemen. It's gone past 8 o'clock. Welcome to all present. Welcome to the Minister, to the members, to the officials, HOD, Dr. Kluter, and also our guests. I hope that all the fire today will be friendly fire from the guests. Before we proceed, let's observe a moment of silence. Thank you. I would like to ask the members of the committee to introduce themselves.
Morning, Chairperson. Morning, colleagues, officials. Dan Plato.
Molweni. Goeiemorgen. Good morning. My name is Moses Timbile-Class, the member of Provincial Parliament. Thank you.
Good morning, Chairperson. Good morning, official. Good morning, Minister. My name is Christopher Fry. I'm a member of this committee.
Ms. Jamche, do we have any of the other members online? In that case, we will proceed. I would like to ask the Minister and the HOD to introduce themselves and their departments.
Morning, Chair. Morning, members. Thank you for having us. My name is Noma French Mbombo, the MEC for Health in the department. Then from the office first, Douglas, you can do it. Thank you. And then over to HOD.
Good morning. I'm Doug Newman, Head of Ministry, Health and Wellness.
Good morning, honourable members. My name is Luke Albert. I am the Media Liaison Officer for Minister Mbombo.
Good morning. I'm Thobela Kandim Mhlubulwana. I'm the Community Outreach Officer in the MEC office.
Good morning, members. Good morning, Chairperson. I'm Dr. Keith Kluti, the Head of Department. Thank you.
Good morning, Chair, Minister, members. I'm Sadiq Karim, Chief of Operations.
Good morning, Chair, Minister and members. Simon Kay, Head of Corporate Services.
Good morning, Chair, and to the members. My name is Nonhlanhla Nkosi, Chief Director of Strategy. Thank you.
Good morning, Chair. Good morning, members. My name is Laura Angeletti Tutwe, Chief Director for Facility and Infrastructure Management.
Good morning, Chair. Good morning, members. My name is Melvin Woodley. I'm the Director of Health Intelligence.
Good morning, everybody. I'm Leslie Shand, Deputy Director in Health Intelligence.
Good morning, everybody. I'm Karen Ching. I'm the Director of Strategy, Policy and Planning.
Good morning, everybody. My name is Santi Roy. I'm the Acting Chief Director, Supply Chain Management.
Good morning. I'm Glynis Denica, Deputy Director in Health Intelligence.
Good morning, Chair. Good morning, members. I'm Ashley Levendal, Director at Health Intelligence.
Good morning. My name is Lauren Koopman. I am a graduate intern in Health Intelligence.
Good morning, members. Good morning, everybody else. I'm Peter Smith, Department of Health, People Management.
Good morning, Chair and members. I'm Andre Luck from People Development.
Good morning, Chair. Good morning, members. My name is Sheila Lubega. I'm Public Health Medicine Registrar in Health Intelligence.
Good morning, Chair. Good morning, members. I'm Glenn Carrick, Chief Director of Financial Management.
Good morning, everyone. My name is Desra Mohani. I'm the Director Management Accounting, Department of Health.
Good morning, Chair, Minister and members. Juanita Arendse, Chief Director, Emergency and Clinical Services Support.
Good morning, Chair, and all the members and Minister. My name is Bernadette Aris, and I'm the Chief Director, People Management.
Thank you for all those introductions. The lady who has just joined us, are you a member of the public or with the department? Thank you. Would you like to introduce yourself? Welcome. Thank you very much. We have also been joined by Member Windvoogel. Member Windvoogel, for the record, if you would like to introduce yourself. Thank you.
Good morning, Chair. My sincere apologies for being late. My name is Rachel Windvoogel, and I'm a member of the committee.
Thank you. I think that deals with the introductions. I'm not sure, are there any online that we need to do? None. Thank you, Ms. Jamshe. Are there any apologies?
Apologies, Chair.
Thank you very much.
Chair, just Member Bunce will join us a bit later.
Thank you. Noted. Thank you, Member Van Vogel. Members, ladies and gentlemen, the purpose of this meeting is to deliberate on the annual report of the Department of Health and Wellness for the year 2022-2023. I would like to give the Minister the opportunity to give us a brief overview remarks on the annual report. And although my procedural officer has given me a deadline, Minister, I'm not going to give you a deadline. Thank you.
Thank you, Chair. Actually, because part of my preamble is in my covering forward. So just in summary, it's about what is in there. But I also just want to remind the House that this is the report from the 1st of March 2022 to the 31st. 1st of April 2022 to the 31st of March 2023, so that when we don't answer about the things from the 1st of April 2023, it's about we're still going to engage around that. But also it is the year at least where we could be safely say post-COVID, in as much that we still had COVID, but which was decoupled with the deaths and also the severity that landed us to much of the health system pressures of COVID in the previous years. So it was the year at least we could be able to breathe, but it was the year that we have to bring almost all other services that will have not been prioritized during the COVID. So it might seem like it was a better year because it was not a COVID year, but it was also part of the year that we have got lots of pressures in regard to trying to make it up, which is we'll never be able to make it up when the services were full. But it also, lastly, Chair, it was the time that we can sit and reflect. What are the lessons from the COVID? So in my forward, you'll hear about how we engage the private sector, the civil society, and then coming up with health is everybody's business, kind of, which is what we're doing now onwards. So it was a year of reflection. It was also the year of having an opportunity to do things differently. But also it was a frustrating year because everything now was coming back, and some of the conditions, they were not only like pre-pandemic, but they were worse than that, like the mental health aspect of it. Thank you very much, Chair.
Thank you, Minister. Dr. Klute, if you would like to do a brief overview, thank you.
Thank you very much, Chairperson, and thank you to the members as well. So as the Minister has indicated, 22-23, very much in our language, became a transitional year. And it's important to understand what we were transitioning from and what we are transitioning to. So in terms of the previous 3 years of tabling an annual report, we tabled very much the impact of COVID. This year, we're talking about a post-COVID reality. And in that year, there were a few things that is of note for all of us. And it's very important building blocks for going forward. So I'll take on one or two of those. The first one is because we were transitioning out of COVID, one of the important things that we had to do is to deal with the impact of disease profile that we could not sufficiently get through because of COVID. So there was a catch up on multiple fronts. But the thing was, we very soon learned in this year, it was just not merely a catch up. Because what COVID did, it deepened socioeconomic challenges for people on the ground. And when we came into a catch up year, we found that where the social conditions worsened, the conditions that we had to respond to was at a different level of what they were pre-COVID. And therefore, mental health then surfaced as a massive challenge for us. And it was not merely just catching up of mental health that we couldn't get to because of COVID. The social conditions has exacerbated the mental health challenge. So mental health challenge really came back after COVID, accelerated by the social problems. The second thing that was accelerated by COVID and the social conditions was trauma and violence. Again, those two things is not resetting at the level prior to COVID. They are resetting at a new baseline, much higher than pre-COVID, and they came at us. One of the important things in the Western Cape is the issue of dealing with TB. So again, TB is one of those things that in COVID, we maybe didn't test as many people for TB. So we had to catch up by testing more people for TB so that we can get on top of TB. And there's a range of other things, but I think those were the most important ones that we wanted to talk about. Our focus as we came out of COVID then, as Minister mentioned, was something called health is everybody's business. And we've put it in a frame that we needed to use what COVID afforded us to not just put the health system back to what it was before COVID, but to design it into a new health system that can respond at things as they come at us in a different and in a more resilient manner. So community-oriented primary care has become a very important building block that we need to expand and work well with. A lot of people on this committee has asked many of the questions that relates to how primary care services will be consolidated in this province. And this year was the one that 10 primary care facilities from the city of Cape Town was transferred. The services was transferred to the province. It was 9 where we were sharing a building with the city, and the 10th one was for Santa Kraal. So that happened in this time, setting up a commitment to consolidate primary care footprint for the province and also then obviously within the city. And then just lastly, Chairperson, during this time, we learned quite a few things, and some of the innovations that came out that we've like fast-tracked into this. This is the year of robotic surgery as well. We introduced robotic surgery at Grootske and Tygerberg. There's a few other things we did. We did emergency medical services in a slightly different model by working with the private sector. We did telemedicine. So we could actually, it's become part of the way that we give service to people is to call them with a call center and work with them. And then lastly, there is differentiated models of care. There's different ways of doing everything. And something that we call service redesign. It's the year that we started really looking at redesigning the healthcare system to do things better, smarter, but ultimately with the needs of the clients that we serve in mind. So thank you very much, Chairperson.
Thank you, Dr. Klute. Members, at this stage, I'm going to allow questions to the Minister and the HOD on their opening remarks, if you wish to do so. If you do not wish to do so, then obviously we will proceed. Are there any questions you would like to ask now? Member Plato, Member Klaas, Member Windvogel?
Chairperson, thank you very much. Listening to the Minister and the HOD, they did not make reference to their good audit finding. Let me pick up on that person to say to the Minister and the HOD, thank you very much for a job well done. Obviously, it's not only the two of you responsible for that, the whole team, and we need to recognize that. It was good to note that, looking at where you have started a couple of years ago and where you are now today, much improvement. You, as well as the Minister, made reference to the mental health issue, and that was one of the issues I pick up on as well. And I note it's an upward trend. Visiting one or two of your facilities, as you're aware, it's full to capacity. Obviously, COVID got a lot to do with that. And then the minister mentioned the socio-economical issues playing a role as well. How must society respond to that? Because it's picked up by society. But society's problem is how must they respond? What must they do to assist? You were right in saying it is not, health should be everyone's business, not the department's business alone. I would love 1 or 2 ideas. Thank you very much.
Member Klaas?
Yeah, thank you, Chairperson. Thank you to Minister and the HOD and all of them for their representation. For me, just I will wanted and appreciated that it will be screened also in the TV in order for us to highlight correctly what is being said. But unfortunately, we already started. But one thing that I don't have a question as such, because this is an explanation of what is happening in the health. And there's no numbers maybe saying that finance cost this thing, we did this with an amount at this moment. But the fact is that I'm happy when they talk about TB. TB is very serious and it's not easy to identify when someone has got TB because you must be first tested. And then now when you said you are in that program, it means that there will be a cure because there is the most dangerous disease that been affected people. Even imagine if you've got fever, but the TB, it continue to be part of a body of a person. But what I can say is that the pandemic COVID that took place, we want to know that how far on your side saying that, yes, we are done, is cured, or is not cured, the disease, the virus is cut. So just to hear from us and that, no, at this time now, it's because some of other people, they said it's coming, it's still there, so we don't know exactly what is happening. Even now we hear from you saying that there's a post-COVID pandemic that is happening. So I will be very glad when I hear that. Thank you.
Thank you, Member Klaas. Member Windvogel.
Thank you, Chair. I just need to get clarity in terms of, are we also speaking on the forward of the MEC? Can we touch or?
Yes, of course. As I indicated, the MEC as well as Dr. Klute, their observations. Thank you.
Okay, thank you, Chair. Chairperson, let me take the opportunity to welcome the input of the Minister and the HOD, and I'm looking forward to a fruitful engagement. The Provincial Minister mentioned that it was a year of reflection. I sincerely hope that the whole of remembrance in honor of our fallen heroes and heroines were part of these reflection. Then secondly, Chair, in the forward of the MEC or the Provincial Minister, paragraph 2, the Provincial Minister mentioned about that the province experienced a full COVID-19 wave. And what I want to understand, MEC, COVID is not over yet, but as people, we behave as if there's no COVID. So I want to understand from the department side, what are you still doing to your department doing to
remind remind our people outside, COVID is still a reality. You still need to be careful. So if I can get clarity on that, Chair. And then lastly, Chair, in the 4th paragraph of the Minister's forward, she mentioned about the 30 million in the 2022-23 financial year to further capacitate our mental health service. And then I think member Plato mentioned that we normally do oversight visits, and I in the past, Khayelitsha has one of those that is close to my heart. And I like to highlight the situation. I don't want to highlight because I know all of us is aware of what is happening in KDH, in Khayelitsha Hospital. So there was a request for 30 million to address the mental health issues. And the high prevalence of substance abuse in society has resulted in an increased hospitalization for mental health. And additionally, there are referral problems with Lentegeur Hospital, causing patients to stay longer than necessary. Some patients who are ready to discharge refuse to leave occupying beds. And to address this, the hospital management proposed a step-down facility. Can the department explain why is it difficult to build a step-down facility at KDH, for instance? And can the MEC also provide information on how a department is comprehensively addressing the challenge when it comes to substance abuse and its impact on health? And perhaps if you can use Khayelitsha as a case study in your response. Yeah, I think I will park there for now. Thanks, Chair.
Thank you, Member Windvogel. Minister.
Okay, thanks. I think the others will be, the HOD will respond to that. But it's starting probably with the mental health. What we did, because as I indicated in the forward, in terms of it's one of those that will find that there is a high level service pressure. But we need to understand that we're not only talking about mental health like a pathology. We also talk about the state of mental well-being for the community. Actually, the majority of the people being affected, they are outside the health system, because we mustn't only focus on the ones that are already have been certified as having a mental illness. And the majority contributing factors is the issues like socioeconomic factors. When you are unemployed, it will impact on you. And research, which has come up from the health impact assessment through the Dr. Moodley and the others, where they saw that even during the COVID, the anxiety and depression, especially among the women, middle-aged women upwards, that's what made us to prioritize the geriatric mental health and also, of course, the adolescent. So you mustn't only focus on the illness when it comes to the mental health, but the whole mental well-being of the society, especially post-COVID. Therefore, that's why, as a Western Cape government, with all other departments, we have taken it up as part of our priority as the whole department. At the HOD's level, the Dr. Kluti, and also with the social development, and also with sports and culture and education, for example, they are part of that committee, and Dr. Kluti co-chairs that part of it. And then it comes to us, where we look at the whole of mental health broadly, but mental well-being, because not everyone will come to be certified and to be assessed and all of those. So we have done that part of it. And then when it comes now to the health services, we made a commitment because previously, before the new law or act of the mental health, where we talk about the 72 hours, hospitals were not built in mind that you'll have a acute psychiatry unit within the district hospital. In Khayelitsha, for example, I'm not sure how far it is now, already building the acute psychiatry unit just there at the back. Actually, almost everywhere. Eerste Rivier, I think probably there is almost going to be completed. So we're building acute psychiatry unit, APUs, as a new complete infrastructures. In others, like the Vredendal, we rearrange some of the wards so that we have, whether it's a 4-bedded or such, because what happens, it's not only about the 72 hours people need to be evaluated, but in some instances that it can take longer whilst they are still at the district hospitals, but not necessarily that they need or they might be ready to be referred to the specialized hospitals. So that's why you mustn't only focus on how many specialized beds, but the bulk of the mental health affected people, they are sitting with us. They are here among ourselves, probably including myself, because it's the kind of a situation, how things are. As the economy of the country goes down, as the unemployment goes up, as the poverty goes up, as the inequalities goes up, and we see when it comes to the crime, some of the cases because of the argument. When someone at 2 a.m. comes in, has been beaten, it's been beaten here at the home, the quarrels and whatever. So there's a whole issue of where we are in regard to look at. So I made an example of in Khayelitsha in terms of the acute psychiatry unit, because you said I must do the case study. However, again, the research they show that clinical aspect of a diseases, actually they count lesser compared to the whole socioeconomic aspect of it. I've been many times in Khayelitsha, not only in the ward, where the ward, I think it was for the 30 beds, but to get so many, and up to the level where we have to put them on mattresses. I'm saying it on mattresses because we have to create more spaces for the beds. But not only upstairs, downstairs in the EC, where we even have to make a makeshift, and then we have to put mattresses. And the contributing factors, substance abuse and alcohol, especially among the males. Yes, we do have the females on the other side, but among the males. So at what extent, when we say health is everybody's business, we might be putting every interventions which we have done, where the team, they even have added more of this specialists to conduct outreaches, for example, not only in Khayelitsha. One time I was in Alexandra with a geriatric psychiatrists who are working for the Alexander and also for the Stekland, but also do the outreach, where the telemedicine for the Nelsport and all others. But we could put as many of the interventions, but if we don't close the tap, which is the issue of the substance abuse, which is now coming to your next question, the substance abuse that is happening there, the alcohol that is happening there, that one, it doesn't need health. It needs all of us in the communities to close the gap. That means the tap that is happening there. Substance abuse in South Africa, if you look in terms of the Act, it is a custodian of the social development. If we look at the Act, it talks about social development. And then I think, I'm not sure, it's a section 44, something 45 within the Act that talks about where as health can be able to bridge the gap, not only on the issues of for now referring those ones who have been like in 72 hours in terms of their rehab, but also our responsibility in terms of the detox. Like we've got the Stekland, that is fully fledged detox there. But remember, detox is mostly for the opium, heroin kind of drugs. For the ticking, which is the major contributors, you don't detox. Everyone will need rehab. The rehab, NGO, social development, whether you need a detox or not. So that's why I'm saying that, again, reminding ourselves, health is everybody's business. We need all of us, each other, to be able to tackle some of these kind of things. I think for the TB and everything that HOD can respond, but quick one is about the issues of test and treat. is crucial, because in some instances it's about where you are tested and then you don't get treatment. But with the interventions that have been happening using the gene expert machines and all of those, it has made things easier. And also for the dashboard, where you could be able to see in terms of where is the high level of TB, and the app. I'll send you now the app where you can be able to do the screening yourself, so that you'll know, because remember TB is airborne. So you might be sitting here or in the taxi and everywhere. TB actually is the one that has always been airborne. By that, before you even get excited about the COVID, that is airborne. Yet we don't even think about TB as being airborne. So you can do your thing using sending the WhatsApp or the SMS, so that you can do the screen, so that you know whether you are prone to or you are in an area where there's a high level. So we are getting there. Kancane kancane.
Thank you, Minister. Dr. Kluter.
Thank you very much, Chairperson. Thank you to the members. So let me start with TB, as the Minister has indicated, and I'll work my way to the other issues. I'll add a little bit with mental health. Just in terms of TB, member class, because the key thing is that we need to test somebody. You're very right in that in TB, it's not necessarily only people with the classic symptoms of TB. You know, you cough, you lose weight, you sweat at night. We have to test almost lots and lots of people to be able to detect TB. Now, one thing we learned in COVID is something called smear positivity. So say we test 10 people, and how many of the 10 people has one positive test? Now we're using, and that's what we started during COVID, we started a TB dashboard. So now you can go every month, it tells you exactly where all the TB cases are, like we used to do for COVID. And again, high caseload in Khayelitsha, high caseload in other areas. But what we're also doing now is the number of people we test. There's a certain marker that if 20% or 17% of all the cases we test is positive, we say to ourselves, we are not testing enough. So what we are aiming for is we want to test 10 people and we want one person or less to be positive. So we want to be to the place where out of the testing, less than 10% is positive. Then we know we're testing enough people, because for every one positive case, we get 9 negative cases. So at the moment, we're sitting somewhere 17, 18%. We want to test more. And when we get to that marker of less than 10%, we know we're testing enough. That's the evidence from international. So at this moment, we're not testing enough. Some areas we must test more. So we also now know where we need to test more so that we can get to that marker. The second thing I would like to go on is to COVID. The members are absolutely correct. COVID is not gone. But let me explain to you what we always expected COVID to do. In the first wave, we didn't have sufficient immunity in the Western Cape, or in the country, or globally. And we knew if we didn't have immunity, the strains of COVID that we had put people that is more vulnerable than others at risk for being severely ill, for them having to need hospitalization, and for them potentially then dying. So wave 1, there was a big correlation with how many people got infected, how many people got severely ill, and how many people ended up in hospital, and how many people died. That's where we needed oxygen, we needed the CT-ICC beds and all of that. Wave 2, we saw the same thing. Wave 3, we saw the same thing. Between wave 2 and wave 3, we introduced vaccination. And the first thing we noticed, the more people are vaccinated, the more there's protection amongst all of us. So by the time we got to wave 4, which is the one in this financial year we're reporting on, we saw what we called a dissociation between those. So there were many COVID cases, but much fewer people needed to be hospitalized. And even much fewer people died. At that point, we had what was called community immunity. Because what that then becomes, and I explain to you now, because what happened is the COVID strain itself has continued to mutate. And every now and then you hear there's another new strain, it comes out. But what we're doing is we are measuring whether any new strain increases the need for hospitalization or increases deaths. Now, ever since the fourth wave, doesn't matter which strain has come, there's been no increase in hospitalization. That's why we could discontinue the COVID beds. There's been no increase in need for oxygen. That's why we don't need the oxygen points for COVID. And there was no increase in deaths, which we monitor. Actually, we have meetings every 2 weeks. And, Member Klaas, Member Windvogel, every 2 weeks, we watch what's happening to the strains. We watch what's happening to the hospitalizations. So our job is to do surveillance, is to watch it. But we always, right at front, Member Windvogel, you might remember the first or second one in the ad hoc committee, we were saying, at what point does COVID almost become like the annual flu? When we say post-COVID, the strains of COVID has now got to that point that its impact is not any different to the circulating influenza and all the other ones. And that is the status of COVID. It has become an infectious agent like all other infectious agents. So we're not post-COVID. We continue watching it. And internationally, the pandemic is over. Nationally, it's over. In the province, it's over. Doesn't mean that there won't be a new strain in 3 months' time, that all of a sudden people get admitted again. We need to watch for that. But the likelihood is much smaller. So that is the context of COVID. And we're watching it now, not just COVID, we're watching influenza A. Because even before COVID, elderly people, people over the age of 65, people with diabetes and other comorbidities are much more at the risk from influenza. And that's why we do the influenza vaccine also once a year, because that's the pattern that we're doing. So hopefully the members are assured that we do what we need to do, we watch it. I think in terms of the public, obviously the public messaging is when any new strain carries with it increased hospitalization risk, then, like we used to call back in COVID, we will then trigger the appropriate response. But up to now, we've not had to trigger anything other than keeping people informed that they must be watching, and elderly people are always at risk in terms of this. So that is for COVID. The third thing, Member Windvogel, that you raised is the wall of remembrance. Thank you for raising that issue. It's a very important issue. We take it seriously. We have taken, since we've done this, we've taken a management decision in our department that we need to centrally recognize all people that passed away due to COVID. But we've also decided at a decentralized level, and remember, this is mainly about our staff members. At the decentralized level, all our institutions, so like Grootskeur is recognizing the staff at Grootskeur. People at Tygerberg, in the rural, they do it all at the decentralized level. The central process, because we were trying to say everybody that passed away from COVID, that became a provincial process. So you can't just say these people only passed away in the health sector. People passed away as employees from other departments as well. So that process is ongoing with the department of the Premier, and we're pulling that together. The big thing there is to get consent from the families of the people to say, we are happy for you to put our name of our family member on that. So obviously it's an individual consent process across all government departments, not just health. But our decentralized teams are making small garden of remembrance with the names of the people. And it's been some very, and they've also invited people to do that recognition. So thank you for keeping that alive with us. And then just the last thing, in relation to the clean audit, so we are obviously very proud of the clean audit. And as you said, the clean audit this year is different from our clean audits the 4 years before. The one big difference, which is a significant difference, is that this clean audit is the first clean audit with no significant findings for our data, our predetermined objectives. That is a very, very significant finding. What it means is the data that you see in the report, the Auditor General is saying there's high credibility on the data that you see, because they've not picked up any significant challenges with the data. And the data team has worked extremely hard to get to that point, and we're extremely proud of that achievement. Just to add one or two things with the mental health, I'm going to ask Dr. Karim just to specifically speak about the 30 million and how much of that 30 million has been to help Lentegeur and Khayelitsha in that access to bring relief. But the minister has touched most of the things. I just want to add in one thing. From where I'm sitting on the committee with social development, education and culture and sport, the realization is, and it's the terms we use, Member Plato, is mental health and mental well-being is actually something that all of us have. All of us have mental health. We might not have a mental disorder, all of us. Some of us do have a mental disorder, and it's also how we pick up the mental disorder and how we deal with it. But everybody has its mental health, because it's on the spectrum that you have very good mental health or you have a mental disorder. So one of the things is, for instance, when we go to the other sectors, every school child has mental health. Everybody that works has mental health. And what do we do together across the sectors to create the best environment that people can have to have the best possible mental well-being and mental health that they can have? And when the mental disorder manifests, that we pick up the mental disorder quickly and intervene to get the best result. And social substance abuse is a key driver of it. Now, there's two things that's done with the Western Cape with Western Cape government. The regulations on controlling alcohol is in a very far advanced stage, and it's about access to alcohol, and it's about availability of alcohol. A lot of things that we've learned, and those processes is through legislation, and it's also changing the powers of the liquor authority. So that's one big thing. DSD itself plays a very key role in countering substance abuse, but the biggest one is doing something together with all sectors, and Dr. Karim and myself play a key role there as well, to give youth options. The biggest thing is, if youth do not have options, it's very difficult to tell a young person not to experiment with drugs or with substances, and it's very difficult to give them hope and alternates to do. So there's one or two very promising pilots that's working, but we're working with our colleagues. One is called Planet Youth in George, where we're working with the whole of society in George. And maybe, Member Plato, that is a useful thing to learn for the committee. Because what we've done there is we go in and we check all the children, all of them, that is in grade 7, and ask them by a survey, how many of you use substances? How many use as unsafe sex? Does your parents spend time with you? Do you spend some time together with friends? And now the whole George community is coming together to try and change the trajectory for the young people, to give them options. The way that has worked elsewhere in the world, substance abuse, unsafe sex, all of those things have dropped significantly. So we're very keen to learn from the George experience and make that the experience across all our other area-based teams that we are working with our other sectors with. So I'll just use, I'll quote that one example. Dr. Karim, just on the 30 million.
30 million, Dr. Kluti, thank you, Member Van Vogel. So for this financial year, 22-23, that's 30 million. It wasn't a lot of money, but we used it quite effectively. So we took 18 of the 30 million for the metro services and 12 of the 30 million for rural services. In the metro, we use the funding to strengthen the acute general psychiatry platform. So that's right across the whole of the metro, including Lentegeur and Khayelitsha. We opened additional beds at Lentegeur Hospital. We used about 6 million of that 30 million for that. So that obviously strengthens that entire basin and the entire drainage area. But over and above that, Member Van Vogel, we also add additional posts for the primary healthcare platform, because obviously we can't just strengthen this referral part of the hospital, we need to strengthen the entire platform. So we appointed a number of people in Khayelitsha and Lentegeur, as well as the rest of the metropole, as Minister explained, on the primary healthcare and community-based platform, so that we can strengthen the whole of the platform. And then in addition to that, we also strengthen our community mental health services as well, because that's also part of a key part of our spectrum of services we offer. And just in the following year, which we'll come to next time, we took 72 million, in fact, of additional funding. So we actually obviously trying to increase this year on year. And exactly as Member Plato, as you've said, I mean, mental health is one of the biggest burdens that we will face and will continue facing going into the future. So for the next financial year, which will come to you next time around, we increased that to 72 million. So we strengthened significantly strengthened the platform with that funding. Thank you, Dr. Kluti.
Thank you, Minister Dr. Kluti and Dr. Karim. Members, follow-ups. Just before we get there, we just want to welcome Ms. Kivitz. Ms. Kivitz, we are in the program. We are where the Minister and the HOD has given an overview, and the members are asking them questions. After that, we will table the report. Welcome. Members, follow-up round. Member Klaas, Member Plato, Member Windvogel. In that order, please. Member Plato. Member Klaas, and then Member Plato, then Member Windvogel. Thank you.
Yeah, thanks for the answers. You make us to have clarity now to know what is happening in our health system. My just clarity question on the issue of COVID, post-COVID. As you said that you are trying to check it each and every time. So my question of clarity is that, are you spending a lot or are you not spending a lot? What makes you saying that you are saving, or is that cost you a lot of money or not? And then there is another question I wanted to ask, is that when you talk about finances and all that stuff, I wanted to know that when one of my members asked you about the finances and the good audit, once we were in Robertson, in Kubela, the clinic, or it's a clinic, it was on the process of want them to build, but they were suffer to get a nice place. Now my question on that is that money included on this finance, or is still being placed? Because the reason is that when the audit is right, but the money, I don't know, it's been given to them to do their work. Thank you.
Thank you, Member Klaas. Member Plato.
Thank you very much, Chairperson. On page 6, Minister, I'm back with your forward. The first paragraph. The very first stupid question I want to ask is, just in a nutshell, a short explanation with regard to your Cardiff model. That's triggered my senses quite much. What is it you're talking about? And your violence prevention strategy, is that transversal, but driven by you, by health, is quite strange that it is not safety and that sort of thing, and that health must do that. Would you just elaborate a little bit on that, please? Thank you, Chair.
Thank you, Member Plato. Member Windvogel.
Thank you, Chairperson, and thanks for making my day, HOD, in terms of the good news that it was part of your plans. I think the Minister mentioned that the mandate, if it comes to drug and alcohol abuse, it's not really the mandate of health. And I believe, and I agree with her, that health is truly everybody's business. And I think it was social development, the Minister said that of the MEC, that it's also not her mandate. And it's not related to this issue, but we like to say as departments, it's not our mandate. We don't want to think out of the box. But with health, it's a bit different because it becomes your business at the end of the day. If you are not engaging, is not speaking to your colleagues, like social development minister, safety and whatever, those departments. So it's for me important that we really have that, what do you call it in Engels? Hey, die Engels raak nou weg. Dat ons die samenwerking, die minister praat so 'n bietjie Afrikaans, sodat ons die samenwerking het met die verskillende departemente, sodat ons die dienste gee wat ons mense verdien. So I hope that is what is happening, because the departments like to say, no, it's not my mandate. So you are only focusing on what is expected from you, but not working together with others becomes your problem at a later stage. So I hope that the relationship is there with your colleagues. Then, Chairperson, I want to in terms of paragraph 5, the last sentence, load shedding. I know it's a serious challenge, and I need to applaud the department for its efforts exempting hospitals from it. And I know the department or the MEC in our last discussion, I'm not sure was it offline or online, but she mentioned that she applied for other hospitals. If I can get an update in terms of that. Then there was also 1.2 billion from the premiers. The premier announced that earlier this year about the 1.2 million investment to alleviate load shedding. Has this had a positive impact on the healthcare in the province? If not, what are the challenges? And if yes, when can we see positive results? Then, Chair, also in paragraph 2, the second sentence, you mentioned about there was about total of 285 infrastructures projects in various stages of implementation. Could you provide an overview of the projects that are either completed or nearing completion, and those facing significant delays? Then lastly, Chair, the last sentence. In the context of widening health inequalities, which have resulted in patients sleeping on floors in our public facilities, how do we define excellence? I really want to understand that. Thank you, Chair.
Thank you, Member Windvogel. Minister, Dr. Klute.
Thank you. I think the team from the infrastructure through Dr. Klute, they will respond on some of those things. But generally, the issue of, I think, Member Plato, it's also links with what Member Windvogel has indicated, that in as much as that we have set of indicators, not only as the province, but as part of the whole South African health system. But the nature of health, it makes us to absorb everything. Like South Africa has been excited yesterday, where we're watching rugby, we're united. But now and again, it's about, why don't you provide an ambulance to be on standby? Because some of us were having heart attacks. What if we're going to lose, and all of those? So even next week, where there will be some shows in the stadium, plus also will be playing semi-finals. New Somerset Hospital, EC, Grooteskier, and whatever, I'm talking about where they are nearer to the stadium. They have to plan ahead to be on standby, just in case people, whilst they are drinking, they'll be fighting and all of that. So whether people are super happy, some things we have to absorb it. Whether people are playing football in a stadium, even if we are not necessarily providing a service there, but you find that you end up absorbing it. When it's dark, it's load shedding, which is beyond the health control anywhere. When it's dark, there'll be people who will have high blood pressures because it's dark or they're nearly been marked. We are going to the festive season. Within the beaches, we still have to be worried. So when you say health is everyone's business, it's because when we took that stand to remind people, it's about we are absorbing everything. I get calls about why is the sanitation in Philippines, whatever, is not working. It's going to affect you. It's the same thing during COVID, that there are so many people in Zara, long queues. Go and manage it. I said, no, it's not my responsibility to manage the queues, but it will affect you, because they are not adhering to the 1.5 meter distance. So it's true, everything gets absorbed by health. So that's why we take a stand and see how we can be able to be steward and assist everyone, even the private itself. We are part of that. So that's why with a VPU, we took a stand. Not only health is everybody's business, but also it talks about the social determinants of health, as according to the general comment in the United Nations in regard to the right to health services. Because at the end, not everyone who has been marked, whether it's 2 a.m., who has been involved in the interpersonal violence or the crime, will go to report to the police station. But everyone will come to us. So when you walk on the road and then you get marked and then you get injured, you don't know who injured you. You might not report the case, but you'll go by us. And then we're getting all of this, but the resources don't follow. So that's why we say that we will take a stand and make sure that we have got the violence prevention unit to collect the data and also to share it with the stakeholders for the implementation. Whether they will increase the police or they'll increase the LEAP, or whether the community will change the behavior, it's supposed to be someone's responsibility, because they've already have the data and it's their public dashboard so that people can be able to have access. Of course, as part of the transversal, Member Van Vogel, the transversal. So when I say it's not, we're not the custodian of the act, it is a national policy. So Substance Abuse Act, it is the custodian of that act, is a social development. But within there are sections that which sector is responsible for what. I'm making an example of the detox, which is we're responsible for. I'm making an example of section 44 in terms of the door, revolving door in regard to that space. So we are part of it, but I'm not the custodian. I'm the custodian of the National Health Act to render those services. In as much as that people might complain about the drains, about not having water, it will impact on us. But I cannot take half money and then put up the bulk water system and put up the pipes. I might not be able to do that because I'm not the custodian of environmental health. In as much as that whatever happens will end up being absorbed by health. So that's what I was trying to highlight. But instead of sitting down and not doing anything. So that's why we were part of the transversal mental well-being, the transversal safety. Safety is also co-chaired by Dr. Kluti and the advocate in the safety department with all other departments involved. So the VPU, we've got our own space where we say we're helping here, but the A, B, C, D, we have to be responsible. We're the part of the area-based teams, but we do our component, but they must do their own because we are sharing them the data in regard to that, because at the end, we are the ones who end up absorbing all of those. So in closing, in relation to the infrastructure going to respond in relation to the issue of load shedding, you'll respond in terms of what we did for the inverters and everything, and the money that we're spending on the diesel, that the money that is supposed to be employing staff to be running the services, but we have to buy diesel. There's no new money coming from the national that is a grant for the diesel, this is a grant for the generators, this is a grant for the batteries, the inverters, no money. It means we have to take the same money and then put it up there. And we didn't even end there. We even went to negotiate with the ESCOM, especially for those hospitals where they cannot be exempted because they are part of the community grid, which is now they will do it for the Khayelitsha and the Easter Refill. So we're not sitting down and saying that, oh, Aramefo doch as but we go there and dial whatever that needs to be done. And then in closing about the hospitals full, I think we have seen it everywhere that the, I think I did mention that the current state where we are, socio-economic, environmental, whatever, it impacts on everyone's health. Therefore, people, and with unemployment, it means that there are people fewer who are on being insured. Even those who are insured, you go to the non-metro, you don't get many private hospitals or even private other health facilities where a billionaire in Beaufort West can go to, or in Vredendal. Because if you are in a Klebrand, where do you go if you are a billionaire for the hospital? You come to us. Let me not even go to the non-metro. Here in the Hout Bay, we have got the Handback, we have got the Misamoyet, you have got the Valley. Whilst the people of the valley, the common, some of them, they might be insured. But for the older persons, for the chronics, where do they go? They come to us. They don't go to the medical doctors for their diabetes and whatever. They'll go there to the GPs for the other things. They come to us. So the issue of, we're saying that the services are under pressure. We're under pressure and there's no new money. The beginning of the year, we started with a 1.5 billion short. And we are the only ones where there's no policy that says, Geen en Gang, we are full now. Kalisha is full, go elsewhere, die outside. We don't. We have to absorb everyone. It means that we have to prioritize accordingly. If you are yellow, if you are a green, you can sit there for the whole 8 hours if you cannot go to the primary healthcare services, because we have to prioritize the ones who are the reds. So that's why I was saying that we don't have that policy that says that you cannot come in, but we have to do whatever we could be able to do. So in some instances, when they're sitting on the floor, just making an example, I think I was wearing Kalbrima, you get an 80-year-old emergency, probably stroke or something, and then you've got a 20-year-old, probably also have been drunk or substance abuse and all of those. And then also I've got one bed, noting in this, like in the EC, some of the patients, actually the beds die within, in the corridors, in the passage, even like in Tigerberg. So you give now, what we call for the one probably has been drunk or has been coming for observation. So you give someone a medication to calm the person down. And then it means that the person now might be not necessarily be conscious, has been sedated. So where do you put the patient who's been sedated? You put the patient, so you have got to choose 80-year-old, old age, and all of those. There's only one bed. So it means that the person who's sedated, why would you be leaving that person on the bed who can fall off? So therefore, in some instances, you'll have to make some kind of because there's no other bed. You cannot leave that person sitting on the chair. So in some instances, it's about where you say that, okay, just put this here for the mattress so that those you are sedated and there's no staff because they are all over the place. So as long as the person gets the best care, but you know that the green patients or those who will be frustrated for not waiting will say, oh, you're on the floor. You're on the floor because you've been sedated. You cannot be placed anywhere. There's no other bed because we have to accommodate that 80-year-old on the bed. So in some instances, that's why we have to look in terms of what is the situation in a particular area. Indeed, ideally, we'll have to have more beds. We've got more hospital, but there's no money. There's no money for that. What matters is about, whilst you might be frustrated for the long wait, frustrated for probably longer administration, but Oxalaya, once you get access to the clinical aspect of it, you'll get the best quality care. But the issue that we've got more numbers is beyond our control, and you cannot turn people away no matter what. Thank you, Dr.
Thank you, Minister. HOD.
Thank you, Chairperson. Thank you to the members. Member class. So the cost of surveillance for COVID. So what I tried to explain to you, we keep an eye on what happens to the COVID strains. Now, when I say we keep an eye, we're working with a network of scientists whose work it is to do this. So for us personally, it costs very little for our tests that we continue to do for COVID, which is much fewer tests, but that specimen gets sent to the scientific lab where they do the DNA analysis of those things. And it's them that tell us that this variant has now become a subvariant, became that, and they're part of a national network and an international network to watch what happens to COVID. So it is scientists in the system that we are connected with. Again, the influence, it's not that we have to pay for the science, because a lot of that money comes from the universities, it comes from the Department of Science and Technology, but we have a scientific network in this country that does DNA analysis on samples that we send from the laboratory for them to track new variants. So that is what we do. The cost associated with what we've done as a response in COVID has significantly dropped, because the cost that we incurred was for increased tests. That is much lower now. The cost we incurred was for additional beds and oxygen, which is much lower now. So those additional cost drivers that we had to do for COVID, that's virtually disappeared. So the money we spent to continue to watch for COVID is minimal, and it's comparable to what we do for all other infectious diseases. I hope that makes sense to you. I will ask Dr. Angeleti Dutoit to touch on 3 infrastructure-related matters. One of them is in Kobela. Many of us have visited in Kobela. We all understand the pressure in Langeberg. We all understand that Kobela is a priority, but it is on a schedule of events. So that same 285 projects we're talking about, that is the one that she will give an explanation of where in Kobela fits on that list of 285 projects. In terms of the Cardiff model, Member Plato, the Cardiff model very simply is, and this is what they discovered in Cardiff at the time, if you depend on police statistics, you see a very small part of real violence in a community. So what the Cardiff model was, that if you go to an emergency center and you see who comes with a stab wound, a blunt trauma, or being assaulted, you pick up much more cases of assault and violence, because not everybody that comes to the emergency center actually goes to the police station to make a case. We actually had a study done in Khayelitsha 3-4 years ago, well, just before COVID, 2019. Only 16 or 18%? 16% of the cases we saw at Khayelitsha Hospital resulted in a case in SAPS. So it just gives you a sense that if you track what happens through health data, you have much better understanding of the quantum of assaults and all of those things. So the Cardiff model is based on, if you bring the health data in, and you bring it in real time, because you can do it in emergency center, you can actually track. And what we've then done is our data then has become the basis now that we can give it to LEAP, to the law enforcement, because our data says yesterday, like last night, our data is available this morning of who was assaulted where, because people came to the emergency center last night. And that is what the Cardiff model basically is. That does go to Member Windvogel and your comment. Why is health playing a role in safety and in violence prevention? So I think, Member Windvogel, the key principle that Minister Mbombo is pointing out to you is we do it in the spirit of samenwerking, right? So that's the spirit. We know we have to do it. If we don't do it, we get the results and the negative impact anyway. The word we use is something called stewardship. And stewardship is, because if we want to make sure everybody is healthy and well, we must actually address all the things that makes them unhealthy and unwell, which means it takes us into a space that we work with law enforcement, we work with DSD, with education, with municipalities to make sure that the conditions are created that people are healthy and well. It doesn't mean that our resources goes into all of that. It is how we use influence. And it's mainly how we use policy influence that makes the big difference in that regard. So we do it in that spirit. That's why I'm the co-chair on safety, together with my counterparts in mobility department and community safety. I'm the co-chair and I'm working part of well-being, which is where education, DSD, and culture and sport work together. And I'm also a co-chair on something called One Health, which is where I work with agriculture and with environmental affairs and development planning to bring environmental health, animal health, and human health together. So that becomes, in a sense, our role as stewards to work with other sectors in that regard. Dr. Angelitwe will give you a quick update of where the 285 projects are, and then also on load shedding. And I'll just remind everybody again, I mean, it is up until March 2023, Laura. And up to that point, Member Windvogel, you're right. We have negotiated, and we have, because of this relationship, we have a relationship with the city, with Eskom, with everybody else. We could negotiate additional exemptions of hospitals over and above the 5. But Dr. Angelitwe will give you an indication of what that was like at the 31st of March, 2023. And since then, obviously, maybe 1 or 2 additions have been added. In terms of the money that you're talking about, it is money actually for this financial year. So it's not in the reporting year. The money is from the 1st of April 2023, the additional money that you're saying. So in the next financial year, we can reflect on that. But by and large, ministers indicated a lot of this additional cost that came about with load shedding is we carrying in our operational budget, by and large, in terms of that. Then just the last thing before I go to Dr. Angelitwe. I think the question that you asked, and Minister Mbombo answered it very well. The question of excellence of care and excellence of service. It's easy, and we could say, Member Plato, we got 5 clean audits. For we are rendering an excellent service to the people of the Western Cape. Whether we render excellent service or not, it's dependent on the people that get the service. It's what their experience is. We cannot define excellence from a perspective other than from what the person experienced when they come to us. And it's from that perspective that we believe we need to start working with the person. So health is everybody's business. A central piece of that is the person that receives the service must tell us whether that service meets their needs. And if you take that perspective, that is where Minister Mbombo, and we are very, very mindful on it. There's adverse events that we follow up. There's people that says, my experience was less than optimal. We follow up, we take it serious. I can tell you in this department, I've been so heartened by anybody that says this was not a good experience. I've not seen a manager saying, well, you to blame. We say, we apologize for your experience. We look into it. If there was really, really bad things that happened, we will not leave a stone unturned, because nobody that comes to our service should be treated with less than dignity. So that assurance I give you on behalf of this department. Dr. Angelitwe.
Thank you very much for the questions, and I will answer first to Nkumbela Clinic. We have been discussing with the local municipality for finding the site, and we are quite advanced in getting the approval for the design and construction. We look at also for some alternative kind of location, like for example, like we did at Mufuleni, where we rent a warehouse and then we built a clinic underneath, but apparently there is nothing available in that area. So the idea we have is to speed up the construction of the clinic, is to do something similar to the Mufuleni, where we have this warehouse and then we fit the clinic underneath. That will speed up the construction quite considerably. So that is one. We hope that the site is going to be available in this financial year, because it's one of our top priority in the department. In relation to the projects, I want to just mention on the page 120 of the report, we have all the list of the capital investment and all the project that and the dates of projects that are due to be completed for the construction. I will update this report because this is only until the end of March, but if is required, I will update the report to give you the current situation on the capital infrastructure program. In relation to the Eskom, we have at the moment we have a 10 facility that are obtained from, and we have been working very well with the City of Cape Town and ESCOM in exempting facilities, and we are working in exempting Kalicha. The problem with Kalicha is, as the HOD mentioned, and the minister is profoundly embedded the network in the area, that if we keep Kalicha on at the moment, we will keep on half of Kalicha. So we are not, ESCOM is not in agreement with that. So we are working together with them to provide a feeder that is taking away the input of electricity from the substation, and is going directly to Kalicha, and then will be possible to keep Kalicha Hospital on during load shedding. Thank you.
Thank you, Minister, HOD, and Dr. Angeleti du Toit. Before we proceed, we have been joined by yet another member, Member Bunce. If you would like to introduce yourself for the record, please.
Good morning to you, Chair. Good morning to the Minister and the Department. I am Ayanda Bunce. Thank you.
Thank you, Member Bunce. And Ms. Kivitz, I neglected to ask you to introduce yourself for the record. If you would like to do so, please.
Good morning, Chair. Good morning, committee members and the department. I'm Damaris Kivitz from the Community Engagement Unit at UWC.
Thank you so much for that. Members, are there any follow-up questions? Member Plato?
Thank you. Just two very short follow-ups from my side. On page 10, looking at the good audit finding of the department, and then right at the bottom, and sometimes when people, the public, see that, how can you receive such a good audit finding, but you're talking in the same token about fruitless and wasteful expenditure. Now, many times the public don't understand that. They regard it as, oh, there's fraud and fraud, but look at the finding. How can that be? How do you match the two? If you could just elaborate on that a little bit. But then on page 11, Dr. Klute, you made a reference to the shortfall of the funding gap for community mental health NPOs. Is it affecting them, or will it affect them? What is the situation there? Thank you.
Any more of the members? Member Windvogel and Member Klaas.
Any small clarity, perhaps I missed it. I'm a bit deaf, Chair. So there was the doctor.
Angeleti du Toit.
Yeah, explain to us in terms of exemptions of hospitals. So I need clarity in terms, because I couldn't pick up if it comes to KDH. If I can just get clarity on that.
Thank you, Member Windvogel. Member Klaas.
Yeah, also mine is so quick. I didn't want to hear that when you are going to have an infrastructure. I wanted to ask on that in issue of the finance. What? Yeah, you're going to answer. Okay, thank you.
Thank you, Member Klaas. HOD.
Thank you, Chairperson. Thank you, Member Klaas. Thank you, Member Windvogel. So just for Member Windvogel, when we negotiate with ESCOM and with the city, we can go to them and say, we want this facility, health facility, to be exempted when you go from stage 2 to stage 3 to stage 4 to stage 5, even up to stage 6. The city comes back to us, the ESCOM come back to us and say, okay, we can do it, because remember, we have to still shed a lot of use. But the way your hospital is connected to the grid, it allows us to switch it off at a point where we can keep the lights on in the hospital while we still shed the power that we need to have. Khayelitsha is so, the supply to Khayelitsha is part of almost the whole of Khayelitsha. So there's no point where you can switch off and then keep Khayelitsha on and the rest of Khayelitsha off. You have to switch. If you keep it on, the hospital, you have to keep the whole of Khayelitsha on. then it's difficult to get the number of megawatts that you have to save, because it's almost then you are not doing load shedding because everybody still continues to use the power. And it's for that we have worked with Eskom to create like a pipe, a line, like a very expensive pipe and a line, which we have to pay for itself, to go to the substation so we can isolate the supply to Khayelitsha. And once we insert that line, they can then switch off the line and they can keep that line on while they switch off the rest of Khayelitsha. So that's what Dr. Anzalete explained. Member Klaus, I understood your question initially. And when you say that we look at the finances for the financial year, right, there is virtually no expenditure against Nkobela for this year, that one, because it is on a schedule to happen in the future. So your question was, when we look at the finances for a year and for this year, it includes no expenditure against Nkobela. But when we do look at the finances and we get a clean audit, it includes all the infrastructure projects we did spend money on in that year. Okay. And then Member Plato, I'm going to ask firstly, Mr. K, just to explain the 18 million, which gets explained later on, but you can explain the 18 million of the fruitless and wasteful expenditure. And then I'm going to ask Ms. Arendse just to explain the NPO funding to the mental health. It's just a technical explanation of what happened there. Mr. K?
Thank you, HOD. So it's 18,000 Rand on a 29 billion Rand budget. It happens. We're never going to be 100% perfect at everything. A fraction of a fraction of a fraction. But we still investigate every single transaction. We don't say, well, it's 18,000 Rand, we're going to forget about it. It's a transaction, it must be investigated, and there are actions that then emanate dependent on the investigation that case. I suspect we'll have a conversation about this afternoon and scope in a bit more detail. Thank you.
Well, at least you've had a practice run. Members, are there any further questions at this point?
The NPO, mental health NPO, project 2, which is the NPO funding, on page 11. So, Ms. Dr. Karim, want to take? Okay, Dr. Karim will take it.
So on page 11, I mean, so we, as part of project 2, as part of that mental health funding that I've spoken about earlier, and part of strengthening the whole of the spectrum of mental health care, we obviously added additional funding to close the gap in the NPO funding of 7.3 million, because the NPOs, pardon, NPOs in the rural areas were funded at a slightly lower gap than Metro, and so we used 7.3 million of the 30 million to close that gap. We also have a very tight process of licensing, by the way, of community mental health facilities. We've got a long list of them, and the very stringent criteria for licensing. So we're making very sure, ultimately trying to prevent the life Esidimeni tragedy. That's ultimately what we're trying to prevent. Thanks. Thank you, Member Plato.
Thank you, HOD. Thank you, Mr. K, Mr. Dr. Karim. Last round.
Yeah, no, it's not a question. I want just to applaud that I saw a rainbow nation here. Thank you. They will know. I saw the rainbow nation, and I say that I saw all kind of race, color, everything. That's what I like. Thank you.
You will see it in the report as well. Sorry, that. Any further questions, members, to the Minister or the HOD? With Member Windvogel? We're dealing just with the brief introductory remarks made by them. We will get to the report in a moment. Thank you. But based on what we've experienced so far on the first 39 pages, it's going to be a bloody long day. But thanks. Members of the public, would any of you like to, sorry, are there more questions?
No, so Sochi, I'm going to go on part A of the report, so that's my questions.
Members of the public, would you at this point like to put a question to the Minister or the HOD in terms of their introductory remarks? Ms. Kivitz?
Thank you for the opportunity. Page 5. The system that has been rolled out and according to the department, very successful. If load shedding steps in at facilities where the system is down, what is the alternative? Because I've seen it and I've witnessed it at some of the facilities where load shedding stepped in and the system were down, and then there was a delay in how the process followed because there isn't a backup. The generator at this particular facility didn't kick in immediately. So many times people say it's a systems problem, but the systems problem is created by people. This is a man-driven system that has been implemented. So how do we ensure that when we invent systems that are electronically set up, what is the backup if the system is down? That's on page 5. Then on page 6, when the minister talks about good governance, over the years, that has always been part of the department's report, is the good governance. Now, if I look around today, then I would like to know where are the statutory bodies that is affiliated and appointed by the department as part of the good governance, because it is those bodies that is supposed to also be here and see how their oversight has played a role in this report timing. So when we talk good governance and we talk about health as everybody's business, I'm sure there are some of us that can say, if health is everybody's business, are everybody included? And the minister will always say there's different communities for different collaboration of people. And the concern we have, and now I'm speaking on behalf of health committees, is then when social capital were part of the department's mandate, health was everybody's business, because this auditorium will be packed when it's annual report timing. And I think we see the demise of people coming, or do they know or don't they know of the briefing of the annual report today? So it raises a concern that when this kind of engagement happens, the statutory bodies are very, very absent. Then on page 7, to Dr. Kluter, the school health program. So the department talks about the services provided. How many schools, at how many schools was this service provided? And is this only in the metro or this across the province? Because if you look at 202,309 learners out of how many learners in the province? So are school health effective? Do we really match what we have in schools, and how many school nurses do we have to match the service that is provided there? Then the home-based care and community-based services. There were 7,342,000 contacts in home-based care and community-based care settings. Now, this number also doesn't tell us how many of this are bedridden clients and how many of this is children under 5? Because if we look at community-based services, we look at a comprehensive package of care for both children under 5 as well as our bedridden patients. Then at the bottom of the page, of page 7, the department says drug-sensitive tuberculosis. So is that your MDR and XDR clients that are mentioned there? Because I would understand that, but if anybody else that doesn't understand what drug-sensitive is, we wouldn't know whether it's XDR or MDR clients that are seen. And then the children under 5. Are the medication for children being dealt with in the management of tuberculosis in the province? Thank you.
Thank you, Ms. Kivitz, Minister, and all the HOD.
I think the system part, they can respond, but generally, what I'm aware of, the hospitals that were exempted, they are exempted up to stage 6, and there hasn't been any stage beyond that that impacts on the system being delayed, unless it affects mostly, as we know, with the radiology, the nuclear medicine, in terms of the rebooting, generally for the hospitals. But in some other primary health clinics, the system that gets affected, it's about the computers related to the admin in terms of the patient records. But it generally, especially in the non-metros, they are not utilizing as much of where there's a need in terms of the delay, in terms of the rebooting and all of those. So I'm not aware of any of those, but the team can be able to respond. But also noting that the rollout of the inverters in the primary care clinic is still continuing, and even now. And also for those that already have got generators, in the metro, I've been to Retreat, I've been to the Vanguard, some of those CHCs in regard to their generators, which is, I'm aware that because now there's been a load shedding. They had generators a long time ago, but because of the frequency of the load shedding up to stage 6, it meant that now they also have to upgrade to a bigger generator, and also side B. I've been there in regard to that. But what the team does, whilst they're having a medium or lower capacity, they tend to improvise by switching off other areas where they might not need much of the utilization of the electricity, like inside B, where you have got outside containers where you find that they have to switch it off. That's general. Now, going to the statutory bodies, I think the same question is about where is the CEO of Khayelitsha, or where is the nursing service manager of Tygerberg, or where's who? Here is mostly the team that is at the head office to represent all others. Statutory bodies are appointed as per Chapter 6 of the National Health Act, which is they must be attached to a health establishment. And therefore, and then I will go to the local or Western Cape legislation in regard to that. So the question is about where are they? They are working within their own facilities where they are attached to. But it doesn't mean that we don't have provincial or the district or whatever kind of engagement. So whilst you say that where are they, it doesn't mean that they are not being effective where they're supposed to be effective. For me, it's about the role they'll play to ensure that if they are attached to the retreat or they are part of the primary healthcare club, clinic committees, I mean, in the cluster in that area, they need to be effective there in regard to the service part of it, to represent the Antisara and everyone else. So whether they are participating in terms of the information that is being presented to the next level, that forms part of what this book that has been compiled is as a result of the information that has been collected. In Beaufort West, that clinician who's some in Bito and all of those, they are not here, but we're talking on their behalf. So it's a similar thing that we're talking on their behalf, but as long that they are participating where they are attached to the health establishment. That's what the National Health Act says. So we do know that we are not perfect. When it comes to that part of it, because we get these issues where some of them, they feel like, there's no even a remuneration, and also it's not worth it to travel, whatever, all of those. So it will always keep on changing. But indirectly through the office of Chief Director, Non-Landlord Director, Umavela, we are trying as much as we can, in as much as they keep on changing and all of those. So thank you. Over to you.
Thank you, Minister. HOD.
Thank you, Chairperson, and thank you to Ms. Kibitz for the questions. So I will start with the three kind of technical. The school health policy that our department co-created and consulted with the education department something like 6-7 years ago. There's a national integrated school health policy. And in our province, we then established a formal engagement with the education department around the implementation of the integrated school health program. So what does that mean? Every year, officials from our department in their district teams, together with the education officials, decides and describe which schools and how many children at school will be targeted and visited during that calendar year. So that is a program that is then consulted. The original place where people consult from is they used roughly the quintile schools as a basis for consultation for greater need, but they work their way through to get maximum coverage of all the children that should be covered in that way. So in that regard, each district then has school health targets with the education counterparts. Each district then decides which staff members will be deployed on which days to visit schools. And as part of that whole program, we also use school mobiles to get to far outlying schools where it's difficult to get to those schools otherwise on farms. So it's a very sophisticated, detailed program that gets implemented. The data that you see here is, again, like the minister said, a combination of data reporting from multiple report points. Now, the auditors, when they want to come and look at that data, there's Ms. Shand, and she's got maybe 1 or 2 more gray hairs than before, because part of our challenges in our audits before is they wanted to see evidence in the school that this child was visited and all of those. All of those things have been put into a very sophisticated thing. That's why we're so proud of a clean audit with no findings in the data, because of the rigor that our teams have put in to be able to say to you, that's where the children is from. In terms of home and community-based care, those 7 million visits is substantive, and they are significant. Similarly, with a data system that records every single person, and that the data system is verified at the decentralized offices. Included in there will be bedridden clients, which according to our classification, we have classification of category 1 to category 4 clients. In there, there will be clarity of how money exactly that is. And obviously, if you're bedridden, you require more home community-based visits than somebody that is ambulatory or walking. That is in there, including how many children under 5 has been reached through those visits as well. And then on TB, drug-sensitive TB is what the word says. It is that your first line of TB medication that you use, the person that has TB responds to that first line of TB medication. Anybody that does not respond to that first line of TB medication then is either single drug resistant or multi-drug resistant. But drug sensitive means non-drug resistant clients. And those figures then is basically for everybody that has what we call the first line treatment for TB, which is you don't have any resistance to any TB drugs. And that detail itself is also articulated there. I'm just going to ask Ms. Nkosi just to reflect on the backup systems. Minister is right, where we mostly have rolled out the Hector system, which is what you referred to. It's mainly in ECs and bigger facilities, those happen to be the ones that will be either exempted or has generators. But even in those cases, you will have unforeseen outage of power, and there's a backup system from our IT team to actually help with that. But as Minister said, Ms. Nkosi will also reflect on generally the systems that we use in our system. Ms. Nkosi?
Thank you very much, Chair. Question from Ms. Kivitz. So indeed, as the HOD has indicated, the system referred to here is in our big hospitals and those facilities that also have emergency that also provide EC services. And as such, in those, we have got backup systems. We've got our UPS systems. So in the event that the hospital itself is not exempt from load shedding, that even when the generator is not working, that we still have some time with our uninterrupted power supplies, that those systems will be able to continue. But generally at our PHC level, where we don't yet have backup facilities, we are able to say for downtown purposes, facilities are able to use our recorded downtown procedures, which include capturing some of the information manually. And then when the systems are back up, we are then able to do the back capturing. So our systems are designed such that they are able to then provide for back capturing, which is done timeously to make sure that the information is not lost. So we are in the process working in collaboration with infrastructure to put inverters into our primary healthcare facilities so that even in cases when there's load shedding, we are able to continue to have uninterrupted power supply to continue to run our systems. Thank you.
Thank you, Ms. Nkosi. Thank you, HOD. Thank you, Minister. Any more questions from the public? Thank you very much for that. Members, with that, we will now proceed to the actual tabling of the report. And I would like to introduce it by saying or making a comment now and not later when all of you may be tired of listening to me. So in tabling this report, I would like to thank the Minister and the HOD for this report. It's the culmination of strong, focused, and dedicated leadership, management, governance, and indeed the stewardship you referred to. Thank you very much for that. Members, so now we are proceeding. I'm now tabling this report, or this report is now being tabled, and the committee will now be, members of the committee will now be allowed to pose questions to which the department will respond. We will do part A first, which is from pages 5 to page 32. Then we will obviously go to part B. Part C actually is supposed to be dealt with SCOPA this afternoon, but I will allow questions on part C if there are any. And then part D is what we will also attend to. And then parts E and F will be dealt with SCOPA this afternoon. So first, part A, are there questions from the members? Member Fry, Member Barnes, Member Windvogel. First round. Thank you, Member Fry.
Thank you, Chair. Thank you. Let me echo your words in thanking the department and the Minister for the report. It is much appreciated. I will start with a comment on page 15, the mental health care services, especially in the George region. I want to commend the department for hearing our cries. I think Member Windvogel and Member Barnes was on the cluster visit week where we saw that there was a shortage of psychiatric beds in George Regional, in the George and Pito municipalities. I'm sure that a certain Ms. Ngome Zulu would be asking for more beds in the Pito municipality, but that's the story for another day. My question is on page 18 now, Red Cross War Memorial Children's Hospital is very close to my heart because that's where I was diagnosed with a scar on the macula in my left eye. So I can't see very well in my left eye, and that's how I got to be diagnosed with that. And the experts back then, and the experts care that is given at Red Cross back then is still, but now is still very much appreciated. The surge in the reemergence of vaccine preventable diseases, that's obviously a problem that is solvable. What is the awareness levels that have been put at Red Cross War Memorial Children's Hospital? Is there any awareness drives or projects or posters to say that, you know, vaccinate your child against mumps, measles, and bordetella pertussis? No idea what that means, but anyway. And then the solid, the second question is the next question, solid organ transplants. Have there been any cataract or eye transplants at Red Cross War Memorial Children's Hospital in recent times? And then page 18, I commend the fact that, still on page 18, sorry, I commend the fact that there is the weekend waiting list initiative that brings down the waiting time for children for theaters. Can I just get a bit more information on that? How does it actually work, and where did this come from, and how does it actually bring down the waiting list, the waiting time? Sorry. Thank you, Chair.
Member Fry, Member Barnes.
Thank you, Chair. Let me take off where Member Fry left. On page 11, mental health. I'm going to start there where Member Fry said we've done oversight visits. And here it's saying that the Western Cape is experiencing an increase in mental health pressures throughout the service delivery platform. Now, Chair, in respect of Project 2, also here on page 11, why are Metro NPOs receiving higher funding than the rural NPOs? I think when I entered, I heard there was some explanation, but it was not saying as to why it happened to the extent that there's a difference in funding. And why are district hospitals not catered for additional beds? Seek to address the root cause of violent crimes in our society. In our previous discussion about the annual reports, the unit status wasn't finalized. If the MEC or maybe the HOD could just give us some updates regarding its current status and adequacy of the 10 million budget expenditure, details, staff levels of employment, and summary of unit activities over the past year. Also maybe highlight significant achievements, what happened in the past year. That will also be appreciated. Then Chair, it's on page 12 under perinatal outcomes. The perinatal working group made recommendations for strengthening perinatal services. I wanted to check, Chair, what are the details of these recommendations and what progress has been made in implementing them? Thank you, Chair.
Thank you, Member Barnes. Member Windvogel.
Thank you, Chair. Mine is on page 7. Point 5, the bullet 5 and 6. Home and community-based care. We really appreciate the positive trend shown in the report, but we are concerned by the declining service standards in home and community-based care. Maternal deliveries and the rise in mother-to-child transmissions of HIV. And could the HOD provide insight into these challenges and explain the circumstances and underlying reasons for these increase. Then also on page 7, the last bullet, you are speaking about 30,950 patients were reported by facilities as started on drug-sensitive tuberculosis. So that's for me. So that's for me a problem. It's really an alarming rate of patient loss to the follow-up. To follow up raises concern. What are the underlying causes and what measures are in place to mitigate the issues, these issues? Additionally, could you provide data on the total number of children with TB, including those under treatment for drug-sensitive TB, and the total number of child fatalities? Then lastly, Chair, on page 8, I must say it is really disappointing to not see Vanguard Hospital on the list. We visited we visited it earlier in the year and saw a number of serious infrastructure challenges at the hospital. Mainly folders are in the corridors, in admin blocks. The filing system is a serious mess, and the hospital has been waiting for infrastructure upgrades. Can the department give us an update in this regard? Thank you, Chair.
Thank you, Member Windvogel. Vanguard. Minister and then HOD.
Okay. Just an NB member Fry. Red Cross Hospital is a tertiary hospital, not only for the province, but also for all other children. We even take children even in Southern Africa. So it's a tertiary, meaning it's a level 3. If I could put it like that, it means that it must be referred. It's a primary healthcare referral or also other hospital to refer, in as much as that it does take up part of the Metro West, but it does also take all other children elsewhere. So the issue of about the awarenesses, like the immunizations or whatever, whilst they can do as much as they can, but the responsibility also must be in the primary healthcare aspect of it. But in some of the things that lend to them, like the issue of the bans, they even have projects with the NPOs in terms of how they can, people, especially in our areas like the Khayelitsha and the informal settlements where there's always fires, especially now going to December fires. So how they can use sand so that to avoid candles falling off and all of those. But generally, it's a tertiary hospital. They can do as much as they can. And of course, the issue of the resources, the reason that I run with some of the colleagues here, I'm looking at them because we're running a part of the peace run for the Cape Town Marathon. It's part of fundraising. So it's not nice at my age to still be running, but we have to do it for them. I should be just sitting at home with the grandkids. So it's part of it. Some of us are here who are doing that. It's part of that. And then I didn't hear the question about the home and community-based care. What was it, the decline? I've got it. You've got it, okay. I wasn't sure whether you mean the decline in the numbers or the decline of the quality, but nevertheless, if you've got it. I think the others also about the perinatal outcomes, the VPU updates. Over to you.
Thank you, Minister. HOD.
Thank you, Chairperson, and thank you for the questions. So maybe I'll start with Member Windvogel's questions. The Minister's just left there. So just to explain, Member Windvogel, so when you say the bullet, these bullets are highlights out of what we will get later in Part B. So it gives you a snippet of all the deliverables. So when we say home and community-based care at 7.3 million visits, right, in home and community settings, compared to 7.4 the year before, be basically saying that that is the number of people we reached, right? So the 1 year compared to the other. When we say maternal deliveries was 90,000 and the year before it was 96,000, it just says that fewer people delivered babies, 6,000 less in the current year compared to the year before. Now for us, that is a good sign because it means that fewer people were pregnant and fewer babies were delivered. So I just want to clarify what that maternal thing is. It is instead of 96,000 the year before, this year we had 90,000 deliveries. That deliveries is in all our birthing units. So it's every place, MOU, hospital for the whole province. In terms of home and community-based care, we obviously would like the 7.4, 7.3 million visits to be one that is quite, what's the word, that goes and grows accordingly because the PHC facility visits will then start becoming less. And that's what we monitor together from a community-orientated primary care. So in our instance, these are just pure numbers. It is not drop-off in performance. If you understand, well, if I understood your question correctly, it is just a statement of fact that this is what happened. If you look at the drug-sensitive TB, that is 30,900 people were reported and started as drug-sensitive TB, right? Now, if you look at the year before was 27,000. Now, to come back to the question of our colleague earlier, the issue here is we are starting more people on TB treatment. So you can see that between 2021 and 2022-23, the one that we're in, we started 3,000 more people. So that means we found 3,000 more TB cases in the year. And when I started that comment earlier, it is not nearly enough. We should be finding more people with TB. And that's why for us, not finding less TB cases would be a concern. We're finding 3,000 more, but we should find more. And of the 3,000 more we found, so the 30,000, 10% was children under the age of 5. So 3,000 of the 30,000 is under the age of 5 years old. So 3,000 out of the 30,000. And then the question that you raise, which is loss to follow-up and the death rate. Loss to follow-up, 90% is unreasonably high, but I will explain that to you now. And there is more detail that Ms. Nkosi and the colleagues can give. But roughly the 19% is when on our register, the person is supposed to come to this clinic all the time. And then all of a sudden on the register of the clinic, the person is not there anymore. So we report 90% of register, people on the register. It doesn't come back to the same place to be treated. But because of exactly that other system we spoke about, the electronic system, we have been able to trace many of those patients that's in the 19% actually attending at another facility. So this is a reporting of what is on the, let's call it the manual system. It's not a reporting of the electronic system where we've reconciled to picking up. I can use the example of this, the nurse in the noon that was like very, very pleased when she told us this. So she had a defaulter rate because she watches. And she had a defaulter rate of something like 15%. So that worried her. 15% of her patients doesn't come back to the noon. She then went into our electronic system and she found 9% of the patients. And Google led to, she found them all over the place. So she felt actually that although it says 60% defaulter rate, 9 of them continued their treatment elsewhere. And her real defaulter rate was only 6%. So then she could say, okay, now I can focus on the 6%. What happened to them? Send a community health worker to find them and to follow that up. So it's a little bit technical, but I just want to explain that what you're seeing as a recorded number, because we have to record what's on the system. Our electronic system is telling us that at least 10% of that defaulter rate actually pitches up at other facilities as a new starter in terms of the data. So I would like to come then back to the question posed by member Member Barnes. Dr. Karim will give an update of the mental health project that you referred to, why there's a difference between the rural and metro. He will also give an update, and I'm not sure whether he wants Ms. Arends to do the update on the VPU, because there is a very clear update on the violence prevention unit. And then also the, sorry, youth banker. And then perinatal outcomes, Dr. Karim will also speak to those three. So thank you for those questions. And then Member Fry, Dr. Karim will also refer to the surge and the transplants. The transplants is actually listed there, and we're very proud of the lung transplant successfully done in that year. It's a very complicated procedure, but he will give feedback on the transplants as well. And I was going to come back to Vanguard as a last issue, but Minister said she will come back in terms of the Vanguard issue. So Dr. Karim and maybe Ms. Arendse, thank you.
Okay, maybe let's start with NPO funding rural. So that's also historical discrepancy in the funding, because the rural areas have less NPOs, often able to offer less services. And so there's been a historical discrepancy. So what we wanted to do with that project money, 7.3 billion, is correct that historical inequities, so that everybody's now on the same basis. And on an annual basis, we put out a call for proposals, and obviously the rural and metro NPOs are then part of that call for proposals funding. So that's now been corrected, and we took that 7.3 million then for that funding. There was the perinatal outcomes. So we've got quite a detailed perinatal outcomes report, and we've had a committee and a group of colleagues that have been looking at perinatal outcomes for long years, something Dr. Klute actually started. And a lot of the proposals in the perinatal outcomes don't require additional funding. So just to give you some example of what the implementation has been. It's been looking at birthing partners, first of all. So, I mean, we work with some of the NPO partners who provide birthing partners. So these are women who go into labor and during their pregnancy to have a partner during birth, because research has shown that those women tend to do better, and the babies born to those women tend to be healthier if they've got someone supporting them. And many of our women are unfortunately single parents, moms, and so they don't have birthing partners. So we've implemented projects like that. The training is quite a key part of our focus areas. We train both our staff in what we call an ESMO-E project, essential steps for medical obstetric emergency, for managing obstetric emergencies. And we also focus quite a bit on training our community health workers, because they become part of that. And the whole range of awareness messages around antenatal care, coming early for booking visits, etc. There's a whole range of activity that we've implemented as part of improving perinatal outcomes. Some of the additional funding that we also got during the following year, which we'll come back to you for, was then to provide staffing to support that whole process of strengthening our perinatal services. And so we provided quite significant amounts of money. In the Metro, for example, the Metro got 72 million additional reallocated funding, and a large portion of that 72 million went into women and child health services to strengthen the service platform. Rural health services did the same, but that we'll come to back to that, because that was in the following year as well. The issue of surge, so every year there's a surge season. Perinatal surge season is particularly around pediatric surge, particularly around medical respiratory cases, basically. So when we have a surge season, we often have to make sure that the additional patient load can be accommodated on the service platform. And so what we do is we tend to move the patients around the service platform depending upon where the capacity exists. And we in fact have a response plan as part of much like we've done during COVID, where there's a team that meets on a weekly basis and they look at the caseload across the province, and then they move the patients around as well. The transplants are listed, and cataract will obviously, as Member Fry knows, is part of that process. Red Cross is one of the only few places that can actually do it, as you describe your experience as well. But the transplants are listed, and in fact, we've been trying to strengthen the transplant program going forward. So not only in this 22-23 year, but the following year, when we come back to you, you'll see an increase in the number of transplants, both for children and for adults. And in fact, in the recent few weeks, members would have seen some media articles that we've put out about the increase in transplant service, because it is one of the services that we obviously cannot afford to lose. It's a specialized service only conducted in this province and only at our specialized hospitals. Thank you, Chair. Did I cover all the, yes, I think I covered everything. Eh? What was there something?
Ms. Arendse, the VPU.
Oh, there was district hospital beds, sorry. Oh, so part of that funding that went in the 22-23 year as well as the following year was also to support additional staffing so that the staff could provide the extra support at our district hospitals. And we in fact went a step further by putting time limits. Ministers and Luke were quite involved in working with us around making sure that there's a time limit on when district hospitals have to refer patients to the next level for specialized care. Because part of our analysis showed that patients were waiting on average about 11 days before they were being transferred. So they were beyond the 7-day period. So we've brought the limit down to about 7 days to make sure that with the additional staff that we've allocated to district hospitals, the care would be stronger and strengthened, and therefore obviously a better clinical quality of care. So there might not have been extra additional beds required, but it was to allow the staff to provide the additional services and therefore obviously improve the care at our mental health services in our district hospitals. Thanks.
Thank you. Then for the Violence Prevention Unit, the organizational design process was concluded at the beginning of this year, around about February. We started the appointment of staff, so the director was appointed and commenced duty on the 1st of September. The rest of that unit, the filling of posts will be on the 1st of November and the 1st of December. Then there's just one postal outstanding. As for the violence prevention coordinators that are out across the entire province, there's 12 posts that have been funded. 10 of those posts have been filled, 2 had to go back out for re-advertising. And then there's an alignment between the area-based team and how the whole of government sort of approach comes together at the local level that is aligned to the community-oriented primary care approach. So 4 of those sites have already commenced working together in that way, and we've received some feedback. And there's 4 more sites coming online in December, and the balance of the 18 precincts that have been identified as violence prevention hotspots will come online by the 1st of April. So it's like, sort of like a phased approach into that direction. Then in terms of orientation, the 10 violence prevention coordinators that were appointed have gone through a 2-day orientation program. There's an ongoing capacity building process that is happening between now and the end of December. And there's also sort of a whole of government collaboration around a communications plan also that is in progress. Thank you.
There was just Member Fry, you also asked about the weekend team. And the weekend team basically is the same staffing. People literally have come in and volunteered their own time. So it is over and above for the staff. They feel strongly about it. And they come over weekends to do catch up because during the week is the other competing work. So it's basically our staff volunteering on a weekend to give additional things.
Thanks for that, Doctor. Please convey our gratitude. It's commendable. Minister, Vanguard.
The reason I volunteered for Vanguard because I was there this month, part of the oversight. In as much as that you are asking about the infrastructure, which is part of the face of the government, actually has been prioritized, priority 1 for the face of government, meaning to do, like the stoop and the paint and all of those small infrastructure things. But already in regard to the service flow, it has changed completely. As compared that in other areas, it used to be like Deermekar, not knowing, like we combine the ones waiting for the dispenser and so forth. But the whole service, it has improved. Now, with the part of what used to frustrate people, the delays, it was the folders, where people now ended up having 3 or 4 folders because it was difficult to get folders. What they've done, if you go inside there at the back there, the admin side of it, you'll see pile of folders up to on the floor, up to that level, and then you think that it's chaos. But you'll realize that what they have done now, they are taking folders as according to the batches, the number, like from 400 to 600, 60, blah, blah, blah. And then they're trying to put them and they've got temporary, they've got a kind of a what do you call that office thing, shelves that can move. They're using wheels. It's a long shelves, but they could be wheeled now. Like you can push the shelf with all the folders and then you can put it at the back. The main thing is about once at least now the storeroom that is outside there that they'll be busy doing, it becomes available. They could be able to take all those folders that haven't been used for a long time, because in terms of the laws, you still have to keep them, unfortunately, in as much as that we might be technology kind of, but they have to. So that part of it, at least now, it will be lesser of when you have to wait for a folder or you ended up having another folder. Whilst they're doing that, they are doing others electronic, so that at least even if you have got the old folder, at least you have got the backup system. So there's a whole lot that has been happening there, not only the admin side, and probably maybe you have seen that the windows, the entrance that used to be used, broken because of the wind and all of those. So all those have been fixed. But the first part is about the whole thing coming from the security going to the entrance, which is they will be starting with immediately. And when I was there, I think the contractor was going to be on site soonest. But for me, the excitement is that the whole flow has changed completely. Thank you to Dr. Johnson and their team. Thanks.
Thank you, Minister, HOD and officials. Members, on part A, are there more questions? Member Klaas, Member Bunce, Member Klaas.
Thank you for hearing good news. But for this thing of the files, it is not right when you are there and then they are going to speed up. They must know when you are coming, everything must be done correctly, because when you saw things, we have to report. Now we are going to this page 9. Yes, if possible. There is overview of the financial results. Now, when I'm checking here, I like to things of the dividends to be mentioned from us, because it's where you want to see the reason of the dividends. Because when you talk about that, we know the reason why there is dividends. So for us now, we want just to check according to this estimate. They use less money. It's close to 2,039. And then when you continue, it's only on estimate, there's been on actuality and other stuff. So what we need is that we want exactly here to be addressed, the reason of the dividends. Thank you. And then we go to number 11, page 11. Elimination of tuberculosis. I don't want to elaborate on that because we did discuss. But the main thing is that what is about malnutrition on this matter? And then we go to the discontinued activities in page 14. When I read here, I heard that there was a continuation of the transports from George to Cape Town. We see the reason, but in this we want to hear from you what was the reason, because I expect on my side that it's because of the new technology that is happening, because I thought that now, because George and Cape Town, they increase very well of helping people. So, but we want also to hear about that. And then at this moment, I can, okay, is it a, yeah. The challenge is in page 25, if I'm right. But the heading says challenges experience in SCM. Are we all in that? In here that we have always, when we attend the hospital, there's a problem of staff. And I don't know, honestly, this matter is being discussed because we hear that we can read, but the matter of the factor when we are doing oversight, people are honestly, or even the doctors are honestly saying that there's a problem of staff. And even they told us straight, they said, no matter they can employ, it will be the money that they receive won't be enough. So they rather struggle on that issue of staff. We want now to hear from you, when is such case, how will you resolve? Because you said, I like that name you're talking about, but I don't remember that every health is for everyone. Yeah, but why now, when there's an issue of staff, there's no resolution? We must hear every time about that. There was, I don't know, is in Robertson on Ashton that they said, if the nurse is not there, there's no work. Ashton, yeah. So when you come to us, we want on your side to not just be written, being explained to us, because what we are going to do after that, when we hear that as a members, are we going to blame each other that as a government we are not doing work, or are we going to blame you of saying that you don't want to employ or you don't ask the man? And I'm very unhappy about this issue saying that you don't have money. But when you see the government itself, when you spend money, and of which you have to ask that money that you need for the staff. I'm just also commenting and asking question that rather than not give you the money for the staff, but you did apply for that, because it is unacceptable when you hear there's no staff and people are sick and people are close to die, while we said every health is for everyone. Thank you.
On that last one, Member Klaas, I know it's not the same budget, but perhaps if we eat less when we go on oversight visits, that money can go to appointing staff. Member Buns?
Thank you, Chair. Chair, I think mine is a follow-up on the question that I've asked on crime prevention unit. I'm welcoming the response that says that vacancies have been filled, but I didn't get that gist of saying what were the activities and if there were achievements, what were the significant achievements on this unit? If I perhaps can get just an indication on that. I don't want to sound like Member Klaas on my last one. I don't know if it's a comment or a question. It's based on the mental health question that I also asked earlier. I think it's on page 11. I think at our last annual report, Minister said we cannot build more and more mental institutions, which makes sense that we should rather look out on a healthy lifestyle. Now, what I want to know, and since then, what programs have been put in place to look at this healthy lifestyle? How did we advocate, or what plan is there? Because the reality is, when we go to this hospital on every oversight visit, you find, be it in Naisna, be it in wherever in the Southern Cape we've gone to, it's overflow of these mental cases. So one wants to know, how does this message that we get here being translated there outside? What is the measure being used? Thank you, Chair.
Thank you, Member Barnes. Member Windvogel.
Thank you, Chairperson. Chair, mine is also linked to members' class question in terms of the transport between George and Cape Town. I just want to understand why was the service ended and how has this decision affected the patients who rely on it, and what has it? I mean, like, is there a replacement or what is happening? Then, secondly, Chair, on page 15. I see that, and I really welcome the fact that you are going to add social workers to be part of the district component. What is the possibility also to add also psychologists to the component? And then lastly, Chairperson, page 20. I just want to check with the department on page 20. I'm just getting the page here. Community first aid respond the intern program. How many people have been employed through this program, and including a breakdown between the metro and the rural communities, and how much is their stipend? Is there a pathway created for the young people to be trained and become EMS personnel in the near future? Thank you, Chair.
Member Windvogel, HOD. Thank you, Minister, if you like.
I think I'll just summarize for the one that comes from member class. The malnutrition part, I think we did, as you also reminded us when we said health is everybody's business. We provide them with the data because some of these, especially with the children, I'm talking about whether it's chronic or acute malnutrition, but the team can also indicate. We provide as a sector when we receive specifically the children malnourished in terms of where they are. The stats is there. But it cannot be only the health role to feed those children. And when the child is malnourished or children malnourished, it means that probably it's a community issue. It means that their parents, although they might not be sick, or their other siblings who are not coming to us, also that they might be malnourished, which is we have seen in South Africa, where we have seen malnutrition that we haven't seen for the last 10 years before COVID. So that's why, as part of the transversal in the well-being priority that the HOD mentioned, where he coaches, we do raise these things in regard whether they should be cost packages by the social development, whether the agriculture could be able to look in regard to those areas and assist. So when we raise issues, it's about other sectors must take responsibility, but it's not necessary that we have to feed the whole community. We don't have that budget. It as much as that we do have some of the component of the nutrition within our service, but not to feed the whole community. Is with the issue of the transport health net, I want to, before they respond, why it was discontinued. But I do want also to talk about the background, because it was one of my pet projects. Dr. Karim may recall in terms of how it was about. It cannot be, we have these anti-SARAs who needs to be picked up on the boom where they have to wait for this minibus, because often they are minibus, and then they are collected and then get into the bigger bus and then come to this hospital where they have to go. Just to make it an example, at the time, the ones that used to pick them up from Nelsport, Maritzburg, will have picked them up at 6 p.m. And then from 6 p.m., they have to go and wait at Beaufort West Hospital at the reception, where the transport will have picked them from all over other farms to all drop them off there at the Beaufort West Hospital, waiting for the bigger bus that has to take them to George. George is a level 2. There they have to be seen by the specialists. It's part of it. It's the people where they say that your cardiologist, your oncologist will see you on a certain day. So they've got a date. They are not part of the Maritzburg Hospital, nor Nelsport Hospital, nor Beaufort West, or even Prince Albert. But their specialists are in level 2 at George Hospital. And then from Beaufort West Hospital, they'll be taken now to George Hospital. Remember, the last time they would have been at home, making an example of Beaufort West, Mamopans, your area. They'll be seen the whole day at the George Hospital, being seen, and then they take, after they're all done, big bus back to be dropped to the Beaufort Hospital, and then take the others and they go to the remote areas. The point that I'm trying to make, what I'm explaining, we are doing it as an extra. Our core responsibility in the EMS is about that emergency. For having all this transportation, all of those, it's the money that we have to find it elsewhere. In some areas, like in the Leeugamka, where they have to wait at the EMS, for example, the EMS. In Merville, they used to wait under the boom there by the next to near NG Kerk, where the team negotiated, at least the caretaker can open it for them. But we ended up saying that there are fewer anyway. They can be picked up from home because it's just 1 or 2 streets in Merville. It's not much. The point that I'm trying to make is about the inequalities that are happening outside the health system or in the country, whether they are perpetuated or whether they're ignored. But we do know it's what the South African has as part of the challenges. We as the health, we ended up have to fix some of those because there's no public transport in the metro. It's not an issue if they've got an appointment back to Tygerberg or to Grooteskier, they'll get a taxi or they get a bus and then they go to. But in these remote areas, there no other way that they can get, because they are supposed to go to those hospitals because they've got a checkup. Like the checkup, it might be in 6 months' time or in 3 months' time, so they will know in advance. But at what extent that they will be able to access resources, any transport coming all the way from Maritzburg, and then you have to go all the way even to Beaufort West. There's no other way. It means that we have to do whatever it must. In the Matsikama, actually, the team there, they used to even negotiate with the local, I think it was in the, it was not also even in Matsikama, even also in the Gravatt or whatever. They have to negotiate with the local guy for the transport and even have to do some of the putting some extra monies so that they could be able to help to get them back. When they say, come on Friday, the doctor is back on Friday for the checkup. But to what extent that auntie will be able to come back when they've got no transport, no nothing. So the point is that whilst we are doing all of this, it was not necessary that we are getting funded for that, but it's about Oxalayo. Auntie Sarah has to be seen by this specialist going to level 2. Now, level 2, which is George, now to George refers to Grooteskier, to this size. With a new technology, with the telemedicine and all of those, with the outreaches, which is now with a super specialist, do they have to go from George, level 2 specialist, to Grooteskier if they can do the telemedicine? Or even if that super cardiologist could be able actually to have a day set up saying that I'm doing the outreaches, and then it goes to the George Hospital to see those patients. So it's a part of things that it's not only, although they put here it's about George Hospital or discontinuation, I think they are looking in terms of all others that, like if you are from the Matsikama, the furthest, Cleveland, I was making the examples of the furthest, Beaufort West. If you are looking from the Matsikama, the Cleveland, Stofflin, whatever, all of those, Those people is about 2 days on the road, because from there they have to go to the Vredendal, and then they have to wait for the all others all the way going to the Grooteskier. In the by the time they have to go back, they are so tired, and in some instances they'll be dropped off on the road, which is too much. So with the telemedicine, and Dr. Klutu going to talk about the robots. Talk about even about the robots, how the specialists do it. But it's not all about the telemedicine. It's about to have some of these mini kind of, they're going to explain. So there is a reason for that. But the reason that I'm putting here is about it links with the resources and budgeting, because you need more staff. Yes, Faku, member class, where are you going to get the money? We started the year with a 1.5 billion shot, which could appoint more than 2,000 staff members, because we need more. There are no health services without health workers. Indeed, the issue that, like we made an example of the Robinson, in the Montague Hospital, yes, Montague Hospital, for example, we have to close the other ward so that everyone using what there were 2 wards there, 1 ward, because you cannot be all over, because that nursing sister had to be all over to go that side, go that side. Therefore, rather put all the patients in 1 ward. You might argue, say, why are you having a male and the female? But there's no other way. Even if you do have the post, not everyone, unless you are staying from there, because most of the people staying there, they are born there, they've been staying there. There's no attraction to attract one to be working that side in that area. So it's all about the combination of the resources and also in terms of the movement of the people. You cannot have a senior specialist who want to go to work in an environment or level 2 in that case. I think one of the issues is like Prince Albert, where who's going to want to go there in that small hospital where you could be able to be working here in the metro? But the same thing, the nurse in the Merville clinic stays in Prince Albert. So it means that that poor is a young woman. That poor woman has to close the clinic at 5 or whatever, 6, in order to travel all the way to Prince Albert, because you don't have anyone who's working, who's staying there in the Merville, who can be able to stay longer than that. So it's a combination of those, but the issue of the resources, it does have huge impact. And then lastly about the wellness, we do have the Western Cape on wellness part of the programs. And also it's not only about people who must go to the hospital health facility to get some wellness. It happens. We've got champions. The team can even make an example of where we have community champions. One typical example that I normally join, because we mentioned Vanguard, is the Bishop Levy's Walking Ladies. Walking Ladies, Bishop Levy's, they do their own thing every Wednesday in Vanguard. They are there outside, even inviting the patients, doing all their exercises and everything, and then we support them. Also in Athlon, the whole thing of the food gardening and everything, again, health is everybody's business. Anyone within your constituencies, you can ask us that how we can be able to access the Western Cape on wellness in regard to how to live a healthy lifestyle, to involve in the exercises. Exercise might not necessarily be like aerobics, like in Bella by you, Mamu Ukivits. They also have dancing classes for their oldies. So it depends how they want to have it. But thank you very much. You can respond to all that with the IFA and everything. Thanks.
HOD, before you proceed, we're supposed to have a break now. Would you like to proceed, or do we have a break first? I'm open to suggestions. Proceed. Let's proceed, and then after that we will have a break. Thank you.
Thank you, Chairperson. Thank you, members. So I'm going to go very quickly, and I'm going to ask 2 people just to fill in. So let me start with member class. So we take your point about we want to get the place where before somebody comes to the health facility, we can draw the file because we expect the visit and we want to do that. So that is our intention, to make sure that files are ready, we are ready to see a patient, and people would want to stick to their appointment and get done as quickly as possible. In terms of the financials, I'm just going to ask Mr. K just to explain to you what that table with dividends means. So Simon, if you can just quickly explain that line on dividends, please.
Yeah, so it's a it's a standard descriptor that is used across all government departments. As a provincial department, we don't have investments, so it doesn't apply to us. But it's the nomenclature that is used, and then the estimate is again, it's the wording that is used. It is we estimate what our budget is going to be in terms of the revenue, and then at a later stage we find out exactly how much it is, and that's how it's done in this particular table. What this table does show is that we collected more revenue from various sources than we thought we were going to. And that's something that we've been doing historically. Thank you.
Thank you very much, Simon. Then your question on TB and malnutrition. A recent study was released, research that shows somebody's nutrition level is a very powerful determinant of a good TB outcome. So we cannot any longer, with that research, not raise that for the treatment of TB, nutrition becomes a very important part. And as the Minister said, we need to now go back to we call it the targeted intervention for HIV and TB. But as part of pockets where TB is very prevalent, we have to look at nutrition and availability of food. In terms of HealthNet, the Minister touched, but very briefly, the 90 hours 48 hours turnaround to see somebody for 15 minutes in Grootskeen. And the Minister explained the disruption to that person's life. One of the things we are looking with, and there's a few very exciting pilots, is that between George and Grootskeen, because of the distance, that we are looking at subspecialist care from Grootskeen being rendered at George without the patient having to go the other way. So the Minister mentioned one pilot, which we're very excited about. It's an intensive care doctor. So no, intensive care, you need to be very ill to be lying in intensive care, be intubated. But for instance, for the cost of very little, what was the cost? One Robert. Yeah. 200,000. Yeah. But anyway, so it's a low cost. I'm not giving you the cost. There is a robot actually going on a ward round. So literally, the doctor, which is the intensivist, the specialist, sits at his computer at Grootskeen. But when the doctors are all on their ward round around the patient's bed, this doctor sitting in Grootskeen, he sees through the eyes of the robot standing with them on the ward round. He can hear what they say. He can see the patient. He can hear what they're telling about the patient. He can ask questions to say, have you done this investigation? What's that? What does that look like? And in a sense, he becomes part of a ward round. And as a specialist, he gives his advice, preventing that person necessarily having to go all the way to Grootskeen to get their care there. So that's just one example of the kind of breakthroughs we have in terms of technology. But the other one is telemedicine. So you can be seen at the specialist in George without having to make that trip all the way to Cape Town. So that HealthNet CETA that you got there was mainly something that we added because we had COVID money. We had to then withdraw it because the COVID money was gone. But we've put a whole lot of systems in place to reduce the number of transport of people coming to Cape Town. And George itself is a very, very useful place because of the distance to look at new ways of preventing people from traveling so far, just for a 15-minute consultation. Then the issue of the staff shortage, I think the Minister has pointed it out, Member Klaus. Every place where you're going to walk into as a committee, I would be surprised if the staff in that facility will tell you that they've got enough staff. It would be almost unheard of that you go into a place and the staff says to you, we think we got enough staff. Because of the workload that is visited upon the staff and that the staff is very thinly spread. So there will always be an impression that people say we do not have enough staff. What we do have is a system where it says this is the available resources we have for staffing. And one of the things that happened in the current financial year, again, it's not last year, so let's talk about last year. it's a approved post list. And that is we translate the money we have that gets voted, which we also bring to this committee. That money we come to you and it gets voted here, gets translated into how many posts can we afford with that money. Then we must take all of those posts that we can afford and distribute them fairly across the province. And that approved post list is what you can work with in your local context. Now, everybody will say, I could do with 2 more staff members or 3 more staff members or 4 more staff members. It is the affordability of the people and the right skills that we have in the system. Preferably for us, I'll come to Member Barnes's question, is that we need to start looking at things that needs to happen outside the health service, that fewer people come to the health service, because that ultimately has to be it. But that is a reality. Member Barnes, very briefly, the violence prevention unit, the intended outcomes is 3 outcomes. The first one is to strengthen a local response in a geographic area that's localized to violence. Now, on that, the 10 posts that Ms. Arendse referred to is for people to go into a local geographic area and bring all the role players together and say, okay, what are we doing about violence? What are we doing about turning the tap down for that? Now, on that, one of the good examples that we can use is, since the coordinators have been appointed, in Delft, there's been a response. The local players are coming together, they're looking at what they can put in place, and people, by all accounts, are very positive of working together to try and make a difference in Delft. The second one is in Hanover Park. They want to make a difference linked to the Philippi police station, which mainly covers the Hanover Park. The third one is actually Swartland. And Swartland on the West Coast is the first place. But that's not the only place where we have these coordinators. Actually, the stories we hear, they're everywhere, and they're bringing people together in this local area. So that making a local difference is a huge story for us. The second one is we look at evidence of what will make a difference. So again, what do make a difference? And the one big breakthrough on this is the parenting programs. Parenting programs is a massive thing. So they're working with DSD again. There's a whole lot of NPOs. And if you do a parenting program well, and you support the parent with a small young child and with a teenager, you can make a big difference in terms of violence prevention. And then the last one is data. And again, it's bringing all the different data sources together so this team can use the data, as I explained to Member Plato, to make a difference in terms of. So that's the intention of what this unit is. And we're deepening the lessons on all 3 of those things. Then just on the mental health, just an example, the wellness programs were mentioned. But in Witzenberg, which many of the members here, and you can remember previously, lots of questions was asked about Witzenberg. You go to Witzenberg now, you'll hear very positive stories in Witzenberg. You go to Klipfontein around the Gooks area, also positive stories. And what they've done in those areas, the 2 things that was the most impactful was to talk to 13 to 18-year-olds. Is to talk to them, engage them, and say to them, what will make a difference to you? Rather than us planning it, let's hear from you. And there's 2 things that we're helping 13 to 18-year-olds with. The first one is how to manage their emotions. So emotional regulation is a very important thing for a young person. That I don't get too depressed or too sad, I'm going to take suicide, I'm going to take my own life, try and take my own life. I also don't get too angry that I want to then get involved in an argument. So emotional regulation is one. The other one is how to solve problems. Just very basic problem solving. If you've got a problem, where do you turn? How do you do it? It's amazing just in those 2 areas, in Witzenberg and what we've been able to do in Klipfontein, by just talking to the young people, how those things are now coming into a very practical thing. So it's not just posters and whatever. It's how do young people learn how to regulate their own emotion, but also how do they learn how to solve a problem. And when we asked them, who will you listen to? Well, they said, we'll listen to other young people. So now we're getting influencers and working with influencers to actually say, how do you get positive messages out to young people? So that's just 2 examples. But the other one I mentioned to you earlier, which is the one in Planet Youth, which we're very excited about, is the one in George, where we also want to see what difference will happen when the whole of community come together to help young people to navigate all of this. And then, remember, Windvogel, the the psychologist is actually part of the team. And I can tell you one of the things that I have from Overberg, from West Coast, that it's just a huge difference that making, by adding a nurse, a social worker, and a psychologist made a huge difference to mental health in those areas, especially in Overberg. And we always hear this wonderful positive stories. And then lastly, IFA, I'm just going to ask Ms. Arendse to Ms. Aris to respond to IFA and CFA. Ms. Aris.
So thank you, Chairperson and HOD. So this is not where we employ people. This is where we as a department go and reach out to the community. So the specific one, you remember in the past, we used to have the EMS short courses, the first aider courses. This is what we reintroduce. So to date, we've trained 109 individuals from the community, and we have also, again, great stories about how it's empowering. So for us is to expand that through the province, that we go out and empower people in the community to have to handle the first, to be the first aid response. But we're not employing anybody in that space.
Add to Ms. Aris, Ms. Aris IFA is the one where we just train people. There's no stipend with IFA, because we're training people from the community with skills of how to do emergency. But CFA is a program that's actually an internship program. And the stipend for that is 4,100. So there's a difference between IFA and CFA. Thank you.
Thank you, Minister. Thank you, HOD and officials. Member Windvogel, you can do your follow-up.
Thank you, Chair. Chair, the minister mentioned about the fact that there's no money and we must dollar with what we have. And I want to understand, I know, as he explained, there's no money. While we understand that 180, I think it's on page 10. I think it's on page 10. I know 180 million is just a fraction of the 29 billion. But in reality is that 180 million is a lot. There's a lot that we could have done with that amount to improve services and at our hospitals. So can we give a reason for the high under expenditure? 180 of, am I mistaken? I'm open to be rectified, to be corrected, sorry. Because I really want to understand, it's on page 8, the table on top. I'm open 180, and if we are not using the money, and there's a lot of issues of shortcomings, but as I said, I'm open to be corrected. Thanks, Jay.
So the short answer is, if you take that 180 and you take it against the fact that we started the year with 1.5 billion shortfall, that's the context. So the 180 is specific things that you did not. Sometimes when we do that 180 and finalize the books, part of it is intentionally not spending the money so that we can take the 180 into this financial year to offset the fact that we're going to be 1.5 billion short. So, Mr. K, you just want to add anything to that? Because I'm giving you a very short answer. So when you see 180 million, and then you enter a financial year with 1.5 billion shortfall, you need to understand that part of our strategy deliberately is to save as much as we possibly can save before the financial year closes, so that we can put the money into the future years to offset our sustainability. But Mr. K?
Yeah, so I mean, we'll probably talk about a bit more about this at Scope this afternoon, but the long and the short is, as part of our organizational ethos and culture, we don't spend money for the sake of spending money. So we spend the money on the things that we need to spend the money on, and then we return anything that we don't use to the provincial treasury. And we did that with COVID. We've done it with many, many things beforehand. What we then are allowed to do is utilize that money in the future to reinvest in something within the health services. And so that's exactly the conversation we're having at the moment with our provincial treasury about how on earth do we mitigate the unfunded wage agreement that we've got in this current year by utilizing some of the savings that we've had beforehand. And you'll see through all of our statistics that we pay our suppliers within 30 days. We're doing what we're supposed to be doing. We're going through and employing people as fast as they're leaving. We're replacing them. So it's not a case of us wasting and not wanting to spend it. It's about spending the money in the right places on the right things. Thank you.
Minister?
Yeah, just to expand, it's not about you wake up and realize, yo, we didn't spend. What must we do? It's about you know that there is a whole issue of about 300 and something million that we have to absorb for the wage bill, whilst there's still discussions on the salary increase. That will happen, because we're talking about 22-23, that will happen 1st of April. Already you will have known part of the MTF in terms of what are the likely shortfalls that is going to come up in the outer years. And then thirdly, you already have the medical, legal, the claims that are pending. They are not yet have been paid, whether this must be still be in court or whatever the process has been there, but you know that you're going to use that money in the following year. So that is part of the money that we're talking about. So it's intentionally that you're not going to utilize, because we're going to get the money for the wage bill whilst the unions are still discussing, whilst there's still no clarity whether we'll get new money for the salary increase. Plus also, anyway, with the medical legal, where claims we have to pay them. We don't want our assets to be attached, just as we've seen in other provinces. So it's intentionally, though, where you leave it for the next following year. So that is a short explanation.
Thank you, Minister, HOD and Mr. K. Member Klaas, we're going to break now, and then we will come back at 20 minutes past 11. If you could please be seated by then, as we were expected to be seated by 4 o'clock on Saturday. So if we could be seated by 20 past 11, please. Thank you very much. I beg you, Member Fry. You can go and have a cup of tea in the members' lounge, please. So I think we can start while we wait for members Bunce and members Klaas to join us. Thank you for being on time, in fact, before time. Member Klaas actually still wanted to ask a last question. I don't know, while we wait on him, let's just, Ms. Kivitz inquired about the lack or the absence of other stakeholders. Ms. Kivitz, the procedure followed to advertise and mobilize, so to speak, this event is exactly the same as was the case for all the other portfolios, and many of which were very, very well attended by stakeholders and members of the public. So it's inexplicable why there's not a better turnout by stakeholders and members of the public for this particular meeting. I just wanted to make that clear. Member Klaas, as you are approaching your desk, I believe your hand was up before we broke up. Do you wish to ask another question?
Thank you. Sorry for being late. When I eat food, I like too much food, so it makes me late. No, it was not just a difficult question. I wanted just to highlight when I asked about the issue of the staff. I wanted just to request that they must first apply for the need of the staff. Then after the reply of the government, then as he did mention the HOD that, but we need that them to apply as the need of the staff, because it's a major issue when we deal about this. So my request is that if they say that we did apply as a total number that we need, and then the response after that, it's where we can say that they didn't fail you, they show you how the shortage do you have, and then you go and replace to those places. And I do understand the answer of the minister when he said other areas, there's no people that they can do that work, they don't want to go there. We know that there's a skills, a training. So you can train those of that area if people did it while the process is there, because there is not only person must have standard then, there is NQ level where you can train up in NQ levels in order the service to be completed. And then there must be the senior who's always in there. Thank you.
Thank you, Member Klaas. Do you wish to respond, Dr. Klute?
So thank you for that, Member Klaas. In health systems globally, in healthcare systems globally, the fundamental point of departure is that healthcare need exceeds healthcare resources. So it's a global phenomenon that people say, if we had everything we need globally, it will be unaffordable. Our point of departure here is that in our context, the healthcare need of the people in the Western Cape will exceed the healthcare resources that's available. So it's something that we also work from. I think the point that you're making, which is a very useful point to make, and that's something that we can incorporate into our planning, is to understand the burden, the healthcare burden, what makes people ill, what do they need for optimal health outcome, and translate that need into what mix of people and at what scale would you require it to do it. So I do think we will take that on board. We are starting a new 5-year planning process. And part of the 5-year planning process is to say, in terms of our planning, we want to take it to the smallest geographic unit where we possibly can plan from. And in this case would be sub-districts. So let's say, what would then be the need or the burden or what we want to do in a place like, let's say Prince Albert sub-district or in West Coast, say Saldanha Sub-District or Matsikama, in a metro, Tygerberg or Mitchells Plain or Khayelitsha. The issue is, even when you come back with that framework, what people normally then say is, what do we need to be able to respond to the healthcare need in that area? The first thing is what Member Binvogel said. You need everyone, not just the healthcare resource from the public sector. We also need the public and the private sector to work together. But you also need other sectors, and you need citizens to also take a certain responsibility. So if that's the basis for a conversation, I think we should be saying what is a people-centered plan to address the challenges in that area. Linked to that is what kind of skills you would have in the system. The long and short of all of that is going to come to one practical reality, is that the resource that you have at any given time is going to be exceeded by the need. And then it's what is probably important for us now as we go forward is on what basis and in what criteria do you say what is fair? Because you're not going to meet the healthcare need everywhere, but what is the fair distribution of the resources that you do have at your disposal? Which is what I explained to you, Member Klaas, is when we say what the post we can afford is we can only afford so many. What's the fair distribution of that post across all the areas? So thank you for that. Yeah.
Thank you, HOD. Members, we have 1 hour and 35 minutes left of this session. If we can't complete the annual report, we unfortunately, maybe for some not so unfortunate, we have to come back after SCOPA this afternoon. So I'm going to ask you to be very precise with your questioning so that we can proceed on the trot. Are there any more questions with regards to Part A, general information from the members? Member Windvogel?
The last one on Part 8, page 25. On page 25. Unsuccessful bidders are chasing awards more frequently. The last sentence. So I just want to check with the department, are there any tenders that were challenged in court? And if so, what are the details of these and what were the outcomes of such cases? If there is. Thanks, Jane.
Thank you, HOD, please. Thank you.
So thank you, Member Binvogel. So at any given time, whenever we place a tender, we go through a rigorous process. Whenever we award a tender, some of the unsuccessful bidders then challenge the process. Not all of that lands up in a court case because there's an engagement, but I'm just going to ask Ms. Roy just to give us a very, very brief overview of the outcome of that process and if there is currently any major cases that has proceeded on to legal action. Thanks.
Thank you. So there are currently no cases in which this is an issue. There have been issues that have been reported through the PFS that are still subject to investigation, which may well take us to litigation proceedings in the future. But at this stage, there's nothing that I can comment on that would highlight that. Thank you.
Thank you, HOD. Thank you. Members, are we done with Part A? Let's move then to Part B, performance information. It's from pages 34 to 133. Can I please get an indication? Questions? Member Windvogel?
Thank you, Chairperson. Mine is on page 34, primary healthcare. What is the latest with regards to the struggles of community healthcare workers? How are the relationship of relations with the department and department and NGOs, and have the demands of the healthcare workers been accommodated, or was there any progress? Remember, the minister of the MEC in a previous meeting explained to us that they are funding NGOs, so they are not in charge of healthcare workers. And my view is when I give funding to an NGO, there's certain expectations from my side that you treat your workers right, or you use the money for the right purpose. So we know there was a lot of, I don't want to call it grievances from healthcare workers. So I just want to check if there was any intervention from the department side, engagements with the NGOs. Then secondly, Chair, on page 35, paragraph 1 and 2, are there plans to transfer any of these facilities to the provincial government in the near future? Or that I just want to know, is the department aware of any transfers to the department? Then, Chair, I want to understand the immediate care, COVID intermediate care facilities of a long-term condition. Can we get updates regarding the Brackengate Hospital staff? Contract, have all vacancies been filled, and how many of the COVID-19 healthcare heroes have been employed permanently, and what happened to the rest of the workers? Then lastly, Chair, page 36. I want to understand how have the number of ambulances and personnel increased since 2019? And is this number enough to handle over 645,000 cases that were attended to during the year under review? And to what extent is the crisis of long waiting times for ambulances? And how many of these are in rural communities? Thank you so much, Chair.
Thank you, Member Van Vogel. Member Klaas.
I won't ask now too much question. I want just on clarity on page 39, where they talk about service delivery improvement plan. I'm only on the point of target and actual achievement. My point is that we have most of saying that clinics are closed, clinics are open, and they said the clinics are going to be removed in state. For just an example, to make this thing to be clear on you, is that in Begweni, there is a clinic that is going to be built up. They said all of them, they go into that clinic, but we do not believe because we didn't hear. But the question is not about Begweni. It's about, are you building clinics or are you closing clinics? That is the question. Thank you. And then we go to page, it's 42. I don't know it has affected in the Western Cape. When you talk about strike action, there was a strike that took place and those the people died in the hospital. And then how does it here in Western Cape affected you, that strike? What had happened on your side? Did it continue? How did you get the remedy for on your side to protect it in order for us to have a fair future? Thank you.
Any more questions from the members? Over to you, HOD. Thank you. Minister, HOD. HOD, thank you.
Thank you very much for members. Thank you, Member Van Vogel. Thank you, Member Klaas. I'm going to start, Member Van Vogel, with the community health worker update. The process that we have gone through is really just to reiterate and relook our policy in relation to the contracting of NPOs. Actually, it's gone through quite a rigorous process again, updating the policy, what is expected of NPOs, and what is expected that we're putting in place in terms of contract management with the NPOs. And we had to do that post-COVID and in light of the unhappiness of community health workers feeling that their rights are not protected. So the first answer to your question is we've gone through a review of our own policy framework in terms of what we expect community health workers to do, and then also the contractual relationships between ourselves and them. That activity has flown over into this financial year, and Ms. Arendse and her team has been working with all districts to get to the point where I was given the last update. All contracts are now in place, and all contracts are being managed in line with new stipulations. A, in terms of what community health workers are expected to do. B, what skills they need to have. C, what resources they need to have and what support they need from the NPOs that's employing them. So it's quite a rigorous process, and that is what we've got in place. That is our own internal process. And what we've also done is to look at working hours. We've also looked at the remuneration per hour, all of those. And actually, the second part, which is outside our control, which is a national dispensation, to give one national dispensation for fairness for community health workers, which is done by the national department. Actually, our province gave detailed input into that process based on our policy and our recommendations of how to make a fair dispensation for community health workers. That process itself, we were given, I attended the National Health Council meeting 2 weeks ago on behalf of Minister Mbombo, and we will be given an update during November. And that is whether the Department of Labour, the Minister of Department of Labour, will do a specific dispensation for community health workers to prescribe the minimum requirements that healthcare workers need so that they are not open to abuse, and everybody should observe that. But we'll get that feedback in November. In relation to the City of Cape Town health facilities, our department is very clear. Minister Mbombo and myself are very clear with our counterparts in the city. Having in this reporting period, 10 facilities come over to us, but outside this reporting period, so since April, in this financial year, we will report next year that additional facilities in Atlantis will be consolidated under us. We have a process, the minister with her counterpart in the MACO, me with my counterpart in the city as officials. We're very clear in terms of our intended process is that all things being equal, we want to move to one consolidated decision for the primary healthcare facilities in the city to be consolidated under the province. We have not reached that point yet, and we've not made a final political decision between Western Cape government and the city. But there's ongoing communication and ongoing lobbying advocacy for our side to make sure that we reach that point. Brackengate, again, the Brackengate situation, as of the 31st of March, which is the reporting period, the official contract of people being employed at Brackengate under COVID resources, and it's back to my answers around COVID earlier. Firstly, 31st of March, all the COVID money came to an end. Secondly, the need of what we use the facility for Brackengate like, which is for increased hospitalization because of COVID, that need has subsided. So we weren't admitting additional people for COVID into Brackengate. So Brackengate as a COVID facility officially closed on the 31st of March. All the resources for the staff that was employed on contract for that COVID facility came to an end on the 31st of March. Now, there was a very contested process around it. What we maintained, and that's the process we followed, is we then opened Brackengate as an intermediate care facility or transitional care facility from the 1st of April. So it changed its nature. We advertised the post for all the posts to be filled at the transitional care facility. We encouraged all the staff members whose contracts came to an end to apply for those posts and to apply for other posts in the department. We have gone through that entire process with the staff established now at Brackengate to operate a 100-bed facility. The beds, as I understood last, is almost, we're running very close to what the facility is. And the staffing, we've filled all the staffing that we needed for that facility. Now, the balance of what's left over is not all the staff members that had contracts. Not all of them got a job at Brackengate. But we also said to them, there are other posts to advertise, and we assisted them in the process of going through all of that. So that's the outcome of Brackengate. We visited recently. It's running as a transitional care facility, not a COVID facility, with staffing in place to do the intention of that facility. Then in terms of EMS, I'm going to ask Dr. Karim just to reflect on the EMS capacity as recorded by you. And then, Member Klaas, the short answer, and this is what came out with Mbekweni, but I know you're saying it's generally. The short answer is we have a schedule that 258 facilities that Dr. Angeletti du Toit reported on. It's a schedule of activities, and we're planning for new and replacement PHC facilities, clinics, and community day centers. The general principle, and that's the principle we confirmed around the new facility outside of Mbekweni. The general principle is we need service points, more service points than there will be actual built, fully staffed clinics and CDCs. So wellness centers, outreach points, satellite clinics, those things are all part of what we need to provide for to give care to people. What sometimes gets confusing is people say a new facility opens. We then need to staff the facility, and people then equate that with an old facility closing. What we possibly will have is we have a new facility opening, and the nature of the service that happened in another facility might shift. But we're not actually saying to anybody, we're closing this facility or closing that facility. So I just want to make it absolutely clear. That's the media statement we put out around in Mbekweni. That is exactly the same that will happen in Kobela. It will happen in other places as well. And then strike action, you see the list there, Member Klaas, and you will see the note at the bottom is at this stage, not all disciplinary actions and recovery of monies where warranted have been implemented. Now, that is just one statement in terms of going across all of these and see what the impact is. Now, in general, the impact has been we have been able to maintain service levels to such an extent that it has not gravely put the health of the public or the patients at risk. In most instances, we've been able to go ahead and provide the services. In some instances, it became a little bit difficult, but in most instances, we have never stopped a service completely as a result of the strike. But where people were not present, which were supposed to do a duty, and they had no reason, and there no formal reason, disciplinary action has been instituted to them because healthcare workers is supposed to be essential workers, and we strictly uphold the reason and the rationale and process that if you weren't at the duty without leave or any formal process, you abdicated your responsibility, and we take disciplinary action accordingly. Dr. Karim?
Thanks, Julie. So in terms of EMS personnel, I mean, it's a combined strategy. Generally, we've got about 1,700 personnel, operational personnel, roughly about 120 vehicles that are on the road any given day. But in addition to providing that service, and you'll see on page 67 under the program, the increase in the P1 urban, AP1 urban response as well as P1 rural numbers. Just the number of incidences that the staff responded to increased significantly. In the metro, it went from about 93,000 to about 130,000 over the last, from 93,000, 110 and 133 over the last 3 years, as indicated on page 67. And it also shows the number of rural incidences increase over the 3 years. But in addition to that, we also busy with a contracting of service tender for the private providers. What we learned during COVID was that sometimes when there are surges, it's easier to contact private providers that we partner with to be able to accommodate for the surges. So not only, rather than employing all the staff only, we are able to rapidly deploy additional resources using the private sector providers. And so we're putting in place a tender for 3 years to ensure that we can have additional response time from using the private sector providers. So there are a couple of strategies that we've employed. We also had a few more vehicles that were on the road now from last year and for this year under review. And all of that combined, we feel has obviously helped us improve our EMS capacity. Yeah, I think that's it. Thanks.
Thank you. Members, more questions? Member Plato, Member Klaas, Member Windvogel.
Just a brief one from my side. A brief answer should be enough. I pick up under various headings on various pages. I think it's page 64, page 93, page 95. You focus a bit on underperformance. Is it a major problem? Is it contained? You can deal with it? Just that's all. Thank you.
Klaas? Your microphone, please, Member Klaas.
The facility that was working for the COVID and then now it's been transferred to an intermediate facility. Just a second clarity that you said you let the post being advertised because of that. According to the good work they did for you, because it was been announced as a very good facility at that time of the COVID. We know that when people do good, they are not only all of them going to be employed, because when it is going to equality, those who are leading, they choose almost they choose those they think that they can work. And it's embarrassing and it's crazy and it's difficult, because when you choose while the people were doing the work, while it was a difficult situation, it is bad. But my question now that I want to raise is that how many you have employed from those? Yeah, thank you. And then the last one, I'm not going to be difficult because it's the last question. I see there's a lot of NGOs and NPOs that have been profited. And I want from you to understand that this NGO, according to clarity, make an example. I saw in Mbegweni, there is an office that is an NGO that people, they wake up early in the morning and then they go and check the children, TB. Are there one NPO or there are different ones? If it's like that, can you mention, according to the community, what kind of the NPO non-profit organization that you are using? Thank you.
Member Windvogel.
Thanks, Chair. I think Member Klaas just, because I asked also the same question in terms of how many was accommodated. But I hope that the HOD will answer us now on that question. Then on the EMS, I couldn't hear the turnaround time in terms of if I make a call for an ambulance, how long does it take for an ambulance to get to the point of pickup of supposed to? I'm just using my aunt phoned the ambulance around 1 o'clock the afternoon. And around 12, the ambulance was not there. So they have to take him with, ask someone to take him to hospital. So I just want to understand that. And then lastly, Chair, to page 39 table, the actual achievement and target for ideal clinics. What are the details of facilities that did not achieve the ideal clinic status, and what are the reasons for this? And then I think member class touched on that question, and the HOD touched on given explanation in terms of the strike action. So we'll not ask the same question again. Then lastly, Chair, in terms of page 47, linking performance with budgets. While we acknowledge the improvement from the prior year, but it must be noted that 54 million is a lot, and there is nothing to celebrate about failing to spend such a high amount. Secondly, what is the number of the funded vacancies that were not filled? Thank you, Chair.
Thank you, Member Windvogel. Minister, HOD.
Thank you very much. So just to come to Member Windvogel, if we come to your question of the 54 million, the 54 million is one line of the 280 million, the one that you previously asked about. And this is in program 1. Now you need to understand program 1. Program 1 is the head office function. So it is what we do at the center as a head office. A lot of what is that 54, and Mr. K will give you the detail, is money that we hold at the head office to do certain things. Now, part of the reason is just because we have the money and we have things, we're not going to spend it unwisely, or just because we have it, we spend it. Mr. K will give you the main reason, Mr. K, of why that 54. My recall was it was medical, legal, and something else. But those are the two reasons why we did not spend it. But he will give you the main reason of that 54 million. Then in the ideal clinics that you ask us about, the ideal clinic status here on that page that you referred to is 80-odd%, right? Let me just get back to the page. It is 84%. So the reason why you're asking us, that balance of that is about 28 facilities, if I count that correctly. That 28 facilities is spread over different places. Some of them are extremely small facilities. And the ideal clinic status is a very rigorous, very detailed checklist of things that you have to go through. My recall, and I can just check with Ms. Nkosi if she wants to ask anybody from, but nobody's here from assurance. But my recall of why people fall short, there is a specific reason, and it's mainly related to infrastructure, and it's mainly related to 2 or 3 other small things that actually is in the improvement plans, something that we will get to in terms of that. So there's nothing major, Member Windvogel, that if you go into those 28 facilities, there's nothing major that is standing in the way of getting ideal clinic status. It's really whether the consulting room is big enough or whether this is added, that is added, and it's based on that criteria. So the next issue was the turnaround time for EMS. Let me just explain that to you. So the incident that you referred to with your uncle and your aunt, invariably anybody that comes and says they wait long for an ambulance, you can virtually pinpoint it to a specific time. And what Dr. Karim was trying to explain to you is the need for EMS is not even all the time. Now, if you call, I can probably guarantee you call for EMS on a Wednesday morning at 10 o'clock, you're probably not going to have too much of a problem on Wednesday morning at 10 o'clock. If you call for EMS on a Saturday afternoon, 3 o'clock, and it's month end, you will wait a long time. So the issue is that the need and the calls that we register on that performance, if we can plot out those calls for you, we can show you how those calls run at a certain level, and all of a sudden there's this huge peak of calls coming in. Huge peak of calls. And it is when people during that peak call that they have difficulty, because during the peak, the capacity that we have is overwhelmed by the amount of the volume of calls that come in. And it's in that instance that we try to figure out ways of how to respond in those peaks in different ways. So it's about redeployment, it's about who is available, how do we reorganize, and to predict those peaks is, you can have some sense of predictability, but in some instances, just, I mean, there was in the weekend of the storms. So then you have a bus accident on Cliffontein Road. I can guarantee you for the next 3 hours, all the ambulances are occupied. So, and then when you have N1 and it is end of year and somebody makes a stupid accident outside Laingsburg, all the capacity. So it doesn't matter how well you prepare for those peaks. There are these one-off incidents that makes it extremely difficult. On top of that, you add the red zones that also flares up. You put all of that together. That's actually the reality of what happens when somebody sits in a call center and has to follow up for all of this. So those are all the factors, Member Windvogel, that influences. So the answer is turnaround time will not be the same with the same capacity, depending on which time of the week, which time of the month, how it is, and what else is happening at that same time. Now, obviously, the team has to move and manage all those moving parts to be able to cope with all of that in that regard. So hopefully that makes sense to you, and we take that very seriously, and we're trying to do all kinds of ways to try and overcome that specific thing. The last thing is when Ms. Arendse was on one of these calls on a Friday night, that she tells us what actually happens. Then you just think of the social ills that just makes the life of ambulance workers just so much more difficult because of alcohol abuse, because of social deprivation, of children being neglected. And that's all happens within a 5-hour period. That you can see that. And that's what our ambulance workers are facing all the time. But that is the context within the waiting time for that is. I'm just going to come back to Brackengate member class. From what Dr. Perez did at the time, and he met with all the representatives, and we took a list of all the people that was employed at the place, and we had an undertaking. We will continue to check who of them have got a job, who hasn't got a job. So out of all of the people that was involved, at the moment, there's currently less than 30 people that has not been employed. It's less than 30. There is an ongoing process of encouraging those 30 people to continue to apply, to continue to go for interviews. But at the moment, it's less than 30. And currently at the facility itself, we have filled 154 posts out of 160. So that is the status in relation to that. The NPOs that you're asking about, we normally don't work with one NPO only. The one that you are describing, I'm pretty sure I know which one that is because I did visit them. So I understand when they go out and they've got a footprint in the community. Our preference is to work with NPOs in communities where they do have a footprint and the communities do know them. And therefore, our encouragement is normally to work with NPOs that already has footprint. The difficulty is some NPOs go through difficult times. Some of them function very well. But as Member Windvogel has said, if there is a problem in the capacity of the NPO and they are not good at doing what they're supposed to do, sometimes NPOs go through difficult times and we have to exit from the NPO because they're not observing the contractual things and we have to go into a contract with another NGO. And those processes are all very strictly observed, but our teams, where possible, want to work with NPOs that's got a local footprint and the people has a history and understand them. Thank you, Chairperson.
Thank you, HOD. Members, more questions on part?
Member Plato, sorry about that. Where we do have underperformance, and you would see it at multiple places. One of the requirements for the annual report is to explain when you are not reaching some of your targets. The Auditor General and Liesl Easier have actually in the audit report, and it will be tabled that you've said, that there is no concern from their side in terms of underperformance for our department. So I just want to put it in brackets. If you take the number of indicators that's not been reached and how far the indicators have not been reached, there is no concern from our side, but it was very good to hear from the Auditor General, without us influencing them, that they don't have concern that underperformance is an issue for our department. What we do as part of a learning organization, wherever we do not achieve a target, we go in and rigorously say, what can we do better? What can we do better? So you need to read it within the context of us constantly asking ourselves, we want to do better. We want to reduce underperformance. We do it all the time. So that's in a nutshell, explanation for multiple places where you see underperformance. Thank you.
Thank you, HOD. Members, more questions on part B? Member Windvogel? Member Windvogel, could you perhaps just move your microphone closer? Thank you.
Sorry, Chair. Page 70, sub-program 4.1, General Regional Hospitals. Perhaps can the department provide us or give us an update regarding the GFUS project? What progress has been made this far in the project and how much was spent during the year under review and what is causing all the delays in the project? Thank you, Chair.
Thank you, HOD.
Thank you, Member Windvogel. I agree it would be useful. Dr. Angeleti Tutwe has got all the details, but it's probably good if we give you a report with all the progress. Progress has been made since we last here with you, and the contract times and all of those have now been firmed up, and the process is underway. Dr. Angeleti, a very high level update. Thank you.
Yeah, I was trying to get the information about the expenditure last year, but the consultants were appointed last year, and currently the project is in stage 2 of the 50M, that is the Facility Infrastructure Delivery Management System. That means that is in concept design. So there is a full team of consultants, working architects, engineers, and so forth, that are working on the design of a concept design. And we spent around about 5 million rand last year, if I remember correctly, in consultants' fees.
Thank you, Dr. Angeleti Tutwe and HOD.
It is in, yeah. So if you do in different stages, part of it is in stage 2, you talk about design. So it is the layout, what kind of services will be rendered, how will it fit on the site, all of those kind of things. And the fees that you have to pay in that is the consultant fees, because the design is done by employing a group of consultants to do it. So that's the fees for the work that's been done to design the place according to specifications. Yeah.
Would it, Minister?
Yeah. So just to add that it's not only for the JOS, it's a standardized for the professional services. It's a standard thing for infrastructure. Just to highlight.
Just for further clarification, would it be correct and fair to suggest that consultants means professional services rendered? Thank you.
So when we talk about consultants being employed, you put out a tender and you ask that we need the following skills: architects, quantity surveyors, all of those, and they need to be able to do the technical specifications for designing the hospital. So that is you contract in the services of an entity like that to do the technical design. So that is what the status is for Klipfontein Regional Hospital. And as I said, we can give you a formal report on all the technical specifications of where we are with the process.
Dr. Angeleti Tutwe.
Just want to clarify the professional service provider and the tender that we were discussing. It has been done by the Department of Infrastructure, because our role is a client and the implementer is the Department of Infrastructure. So at the moment, the project is implemented by the Department of Infrastructure.
Yeah, the word consultant is a red light word. So for all the wrong reasons, I think in some cases, and particularly without a Department of Health. Thank you. Members, more questions on part B? Member Windvogel?
Yeah. Yeah, I just want to know an update regarding the Ladysmith Clinic replacement.
Ladysmith.
Page 98, high performance provincial health systems for people, district health programs is a grant, comprehensive HIV and AIDS component. Oh, where am I now? No.
Yeah, I just want to make sure because I did visit there recently and I saw it being very close to completion. Yeah, so it is a Ladysmith clinic. That's what it says in the middle there, that 2 targeted projects did not achieve practical completion. They are Ladysmith and Neisner. Yeah, so I visited since, remember this is March. I visited since March. And my understanding, Laura, it is, if not completed already, October. Yeah, so it's this month. Yeah, I was there about a month or so ago, and it is virtually complete. Yeah.
Thank you. Members, part B? Any more questions? Going on. Going. Thank you. Could I at this stage maybe just ask, I know we still have to do part D. The members from the public, do you have any questions on either part A or part B? Ms. Kivitz?
Page 11. Let's go back there. The future plan speaks to the department strategic plan 2020 to 2025. What happened to the strategic plan of 2030? Because there's no mention of that in the future plans. And then the sites, also on page 11, project 2, around mental health. How many mental health, community health workers in our NPOs have been trained to render an effective mental health community-based service? And if they are trained, where are they placed? And then project 3, additional hospital beds to be made available at Lentegee Hospital and George Regional Hospital. And that is 10 beds each. So how was these 2 facilities identified? And is that the hotspots in the province? And still on page 11, eliminating tuberculosis. We see an increase instead of a decrease. I know the sputum, the smear, they are always confusing. But the community outreach programs for tuberculosis. Previously, we had the DOT system, which worked effectively. We no longer have it, and we see what's happening. I see very little change in the community of Eitzig. So are we re-looking programs that has worked to maybe just better the service around tuberculosis? Then on page 12, reducing the surgical backlog. We know what theatres looked like during COVID and post-COVID. Has it reduced significantly? If not, what are the current challenges that we have around there's still being a backlog. And then the perinatal outcomes. There's no mention of the SDG goals around perinatal. So I'm just wondering, how is our community services programs integrated into the service that we're talking about? Then on page 13, the vaccination integration, have we seen a reduction in the vaccination defaults in children, and especially with regards to the measles outbreak that we had recently? And then still on page 13, community-orientated primary care. Are we on par with making sure even in our rural communities that, because there are still people that doesn't have an understanding of why they see a nurse instead of a doctor. So do we have a communication strategy around ensuring people understand a community-orientated, a nurse-driven service? That's what I actually wanted to mean. And then on page 14, the forensic pathology services, I also saw it somewhere else in the report, but I wanted to know on page 14, is the observatory forensic services commissioned? And if it is commissioned, is it running without the challenges that it had prior being commissioned? And then on page 27, in the conclusion of Dr. Kluti, he sets our reset agenda, and the department slogan, I believe, is health is everybody's business. Now, if health is everybody's business, we shouldn't be leaving anybody out. However, the department has bilateral agreements with universities, and that bilateral agreement, I think, and it's my opinion, it's not effective when it comes to community-driven services, because the bilateral agreement speaks to student placements as well as numbers. So, when we look at the reset agenda, it must include everybody that wants to ensure that health is everybody's business. So that is just and then on page 36.
Can we just stop there and just deal with part A quickly?
Okay.
And then I will give you another opportunity for part B. Thank you. HOD.
Thank you very much. Thank you, Ms. Kivitz, for these questions. So on page 11, Healthcare 2030. Healthcare 2030 is our long-term plan until it's replaced by something else. So what is referred to there is the 5-year strategic plan, which was from 2020 to 2025. As I mentioned earlier, we are in a process to talk about the 5-year plan for the last 5 years of health towards Healthcare 2030. And after that, towards probably in the middle of the next 5 years, we'll talk about a Healthcare 20-something that replaces 2030. But 2030 is very much our guiding frame. But many things have moved since we adopted 2030. But the original intention of 2030 is still observed and guides these 5-year adequates. So 2030 was adopted in 2013. So 2015 to 2020 was the first 5 years. This one, 2020 to 25, is the second 5 years. And the one that we're about to submit, 25 to 2030, is the 3 5-year plans towards 2030. In terms of community health workers trained in mental health, I'm going to ask Ms. Arendse just to reflect on that. So Ms. Arendse, if you can just reflect on that community health worker for mental health, but also the community outreach for TB. If you can just deal with those 2 issues, I'll come back to the others. Thank you.
Thank you. So the community-based mental health program is predominantly got its own service set of community health workers within the residential facilities, within the group homes, etc. And so they are trained within the mental health space. But as far as the integrated community-based services, CHWs as we know them, are trained, there's a module that focuses on mental health, focuses predominantly on prevention and support. And it's also then linked into the making every contact count, which is the new sort of strategy that we are busy moving towards in the province. It's still at its infancy stage, that particular policy. So we are busy with the implementation plan and piloting various models. So it's in progress in terms of that one. And then the second question was around the TB specifically. So in terms of the patients are all, according to the differentiated models of care, aligned to the model of support that they require. So we acknowledge the fact that it's not dots in the way we used to do dots before, where the majority of the patients were supported through that mechanism. The proportion is a lot smaller in some of the facilities, and it's really dependent on patients, their work, and all of that. Some of the patients still have dots at the facility. Some of them are still dots within the community, but a vast proportion of the patients receive their medication through other mechanisms and are supported more remotely than it used to be in the past. And I think that's also some of the lessons that we learned through the COVID period as well. Thank you.
Just to add to those two, so the intention with the integrated community health worker is to have the ability to go into a household and manage everybody in the household according to the need of the people they found in the household. So therefore, every community health worker should go through the module that they can ask questions about mental well-being and support generally in the household. Secondly, every community health worker should know that somebody in a household has got a chronic condition. If it is TB, they need to know what is the support this person requires. If it is HIV, they need to know what support. If it is TB, if it is hypertension, diabetes, they need to know what support. So it's about giving the skill to the community health worker to be able to support that family and then know where to refer if everything is not ideal for that person. And make every contact count, right? Is designed to say that when you do have that, you can look at the needs and then respond accordingly. Then in terms of the surgical backlogs, Dr. Karim can give you an update. This financial year that's passed, the one that we're reporting on, have achieved significant impact on the surgical backlog. So Dr. Karim?
No, absolutely. Thanks, Dr. Kluti. So as you do know, the surgical backlog was a major consequence of COVID, obviously. During the 2020 year, our backlog was estimated at 37,000 for that year. 2021, that backlog was estimated at 31,000. For 2022, as Dr. Kluti mentioned, we significantly dropped that backlog to just over 11,000 for that year. So we put in a significant amount of effort with the additional funding, but mostly also with the hospital facilities' own funding. They all have catch-up plans for the surgical services. Because we this year, this report ends 31 March. For January to March of 2023, that backlog is now 5,000 for that year period. So we've put a significant amount of resources into catching up with surgical backlogs. Obviously, the focus would be on the urgent cases first, like cancer care, or the ones that are quite urgent that require theatre. So that's been elsewhere in the report there are references to some of those plans.
Thank you, Dr. Karim. Perinatal, I can just give you undertaking that because the perinatal work is really looking at pregnancy for mothers, the outcome of the pregnancy in terms of births, the young children in terms of them being born and what the outcomes are. There are two major indicators that is tracked. So the first one is maternal mortality. So definitely linked to the SDG objectives. Our maternal mortality in this province has significantly decreased over the years. Unfortunately, because of COVID, it then peaked in the COVID periods, because COVID specifically also affected pregnant women. But since COVID, again, with the national notification of maternal deaths, it has come down again. So we still have the lowest in the country. It peaked in COVID and it continues to be low. The other big indicator we track through the perinatal work is the neonatal mortality. So that is deaths up to 28 days. Yeah. So neonatal mortality, so there's early and late neonatal mortality. Again, our neonatal mortality in this province is by far the lowest in the country. And we have got to levels where people, like, it's really good. It's 7 per 1,000 or, yeah. But it's a very low figure in terms of, so those are the two broad mortality figures that's tracked by the perinatal work. And as Dr. Karim said earlier, it's a range of things we're doing. It's the partner in birth. It's all kinds of things, training, looking at facilities where births happen. So it's really it's also a benchmark, because I went to 1 or 2 meetings and globally people are very interested to understand what we're doing, to learn not only for the country, but for in other countries across the world. In terms of the vaccine integration, the big focus here was that COVID vaccine shouldn't be alone standing. Again, we wanted to make sure that COVID vaccine is part of our vaccine offering. The tragedy, I think, it is sad. One of the unwanted parts of COVID and the COVID vaccination is all the unwanted attention of people using disinformation and misinformation about how safe COVID vaccines is, and it's all the kind of stories that was spread around COVID vaccination. It's had a negative impact on people taking up general vaccination for children. So part of our sad thing, unfortunately, out of COVID is we now need to go back to parents to reassure them about having their children immunized against childhood illnesses. And again, it's now a steep challenge for us to go back to try and see that the messaging about the safety and the necessity, it took a long time to convince parents to vaccinate their children. We now have to start again, because some parents are questioning it on the back of what they heard about COVID vaccines. But the idea is that we now need to just do the hard work again and continue to work hard on that. That brings me to the COPC, the community-oriented primary care. And we agree with you. Me and Dr. Karim and a few others, we visited West Coast last Friday. And I'm struck, and I agree with you, that we need to come back to our communications. We need to go back to comms to explain to people what do we mean by community-oriented primary care. What are the basic messages about community-oriented primary care? Because we talk that language and throw it around, so it would be good to go back to first basic principles. And the basic principle of a community-oriented primary care is that in the local community where people live, you want to get community health workers and basically a nurse-driven service to achieve the most that you can achieve to keep people healthy and not needing to go to a hospital and all of those. And it's important that we actually get that message out and describe that to people and get the buy-in, as you rightfully say, that this is actually the right way to render healthcare services. To go to a doctor-based service, which is a hospital-based service, is almost a default. And we need to be actually protecting hospitals by keeping people healthy, not needing to do that. So there's a lot of work to be done. Agree with you, and a lot of work to actually work with all partners, as you say, in health is everybody's business, that NPOs, civil society, communities must walk this path with us in terms of the importance of that. The OFPI, very shortly, the Forensic Pathology Center in Observatory has been commissioned. It is functional. It had a few blips and a few challenges, but the service is being rendered as we speak at the observatory facility. The reset agenda, you are right. And it was something that is close to my heart when we do speak to our colleagues in the universities, that when we have a bilateral agreement with them, it was signed on the basis of a multilateral agreement. The multilateral agreement was signed in 2012. The bilateral agreement was signed in 2020. Health is everybody's business is 2021. So the issue is we have gone into a relationship with our HIs and said to them, can we challenge that our relationship goes beyond what the basis of the bilateral is, which is just, are we paying for staff that works for both? And are we placing students? If you listen to health, health is everybody's business. Health is much broader than just placing students and paying staff salaries across the two. The universities have been very good to rise to the challenge. And we have got an agreement with them that we are much more broadly focused on a wellness agenda, a outcomes agenda, and it goes way beyond what we might have assigned in the multilateral, in the bilateral. Whenever the chips come down and we really have to talk how we're going to do it, then universities will tend to go back to, okay, so is my students accommodated? But we remind them and we walk a journey with them. So I agree with you in terms of that. I must be honest, I wrote page 36, but I didn't note the last item. So thank you for that. If I give you the short answer is, the pressure points in terms of mental health care beds was disproportionately felt at Lentegeur Hospital and disproportionately felt at George Hospital. Now, George Hospital is because of the distance to the metro. So if you take Paarl Hospital, Worcester Hospital, they still have distance to the metro. George is remote. So the pressure in mental health then builds up in that system. Whereas you can have a little bit of relief for Worcester and Paarl into the metro. But Lentegeur, as the three psychiatric hospitals, is a combination of that the places that drains to Lentegeur has got the highest social burden in the geographic areas. So you have a combination at Lentegeur where Khayelitsha and Mitchell's Plain and part of Klipfontein refer to Lentegeur, together with some of the parts of Cape Winelands, that those areas that drains there has got higher burden than other areas. And one of the key challenges is that those acute mental health care burden is driven not only by social determinants, but as we said earlier, very much by substance abuse. And because of that pressure, there's a pressure point at Lentegeur that was a bigger pressure point than anywhere else. And that is on child and adolescent psychiatry. So you can imagine of young people affected by drugs and all of those. So these 10 beds then went specifically into Lentegeur to help with the acute service, but then also additional beds for child and adolescent psychiatry. Thank you, Chairperson.
Thank you, HOD. Ms. Kivitz, you can proceed with Part B.
Thank you, Chairperson. I'm aware that this is the last reporting in the political arena, because next year we're going to elections. So thank you for the opportunity given. I don't take it lightly. On page 37, under forensic pathology, a total of 52 bodies was unidentified. What pressure does that put on the facilities if we have that amount of bodies unidentified? And how can communities, you know, I mean, we had a case recently at the pathology in Tygerberg, unknown person, and within a few days, the community became aware of the incident and the body was released. So is there a plan for those unidentified bodies that are stacked up somewhere in the mortuary that communities can maybe assist in relating the message? It comes back to communication. Then on page 39, the Ideal Clinic. Very interesting since its inception. Are staff still, is it still part of staff's KPIs that part of the Ideal Clinic is the functioning of a clinic committee? Because I can remember the conversation with the National Department then was, how do you identify an ideal clinic? I also see the footnote that the City of Cape Town clinics is not part of that. I would like to know if the 10 clinics that was incorporated in the previous financial year, whether they are part of the ideal clinics. And that will conclude my questioning. Thank you, Chairperson.
Thank you, Ms. Kiewitz. Had I known that, I would have allowed you to do part B, but it's fine. Thank you. Dr. Glitter.
Thank you, Chairperson. Yes, just a short answer to Ms. Kiewitz on the ideal clinic. Part of the domains, and you rightfully said it earlier, when it comes to governance domain for an ideal clinic, the functioning of a health facility board is one of the key things to look at. So it is definitely part of the domains. It's definitely part of what people have to account for, show the minutes of the meetings and all of those. So it's part of the assessment. The second issue is the note that you see at the bottom, right, is that in this section, it excludes the City of Cape Town facilities and facilities that did not conduct an assessment. It therefore differs from what you see in the rest of Part B, which includes all of that. So when we come to the tables, in the tables, it actually shows all of them, including the City of Cape Town. But just for this one, in this table, it was because of the reporting for this specific one, the detail that the City of Cape Town. It doesn't mean City of Cape Town doesn't do it. They do it. It is just that in this specific one, we excluded that. So City of Cape Town definitely does ideal clinic. They also do Office of Standards Compliance, which follows on from ideal clinic. And there's a whole process with our colleagues around that. The FPS, the forensic pathology, is actually quite an interesting question. And we had a presentation from Ms. Bonita Thompson, which was really, really encouraging, where the forensic pathology, what they put in place to be able to identify the unidentified bodies. The biggest holdup for them is DNA analysis and being able to run the fingerprints of the deceased through a DNA database that's held nationally. They have persisted and persisted, and I can promise you the numbers that we have here has run down significantly because they've been able to clear the number of bodies that's not been claimed. But I mean, her presentation was just so heartening that our colleagues, and it was such a wonderful thing to hear, that our colleagues are saying when they work in forensic pathology, they've never closed what they do unless they can bring peace to a family. That's the basis from which they operate. So as long as there's an unidentified body, there's a family that's not at peace. And that's why they're doing this, to pursue that, to make sure that every single body can be identified. So thank you for those comments. Thank you, Chairperson.
Thank you, Dr. Klute. Members, we will now proceed to Part D, Human Resource Management, page 152 to page 206. Questions there, please? Member Windvogel.
I only have two questions, Chair, on page 166 of Part D. I just want to check with the department what were the reasons for the 70% vacancy rate. What are the reasons? Page 166, challenges faced by the department. Yeah. And then on page 175, what is the difficulty with filling the vacancy of pharmacists? Thank you, Chair.
Thank you. Members, more questions? Member Klaas, your microphone, please. Your microphone, please.
Yeah, there is just one about so 193. It's about race. 193. If I'm correct, it's about race. There is an issue of race saying that when you are in hospital or in doctor, they check, they assist people as equal as all in South Africa. But we need to understand how does the process that the the clinic or the hospital itself play to make sure that they've got their passport, or they help just when they see are lying on the, they come as sick as it is? Because the issue is that most of time we hear or we see that some of them, they are not registered in South Africa. Immigrants, such like that. Yeah, the question, how do you deal with that situation? Someone is here and is not registered, or it doesn't have even a passport.
I don't know whether it's a matter of race or nationality, but I'll leave it to that to Dr. I'll leave that to Dr. Kluter. Thank you. Members, any more questions? Dr. Kluter, over to you.
Thank you very much, Chairperson. So Member Van Vogel, you'll notice the 7% vacancy rate is quite a low vacancy rate compared to what you will hear quoted as the experience in many places. So just you've also gone to the place on the table where we show the comparative, right? But it is a 7% vacancy rate. And there are two reasons really for the vacancy rate. The first one is, in most instances, the vacancy rate in highly specialized areas, or where the skills is the biggest shortage, is disproportionately higher compared to other categories of staff. So if you go to big hospitals, central hospitals, the vacancy rate in theatre nurses is slightly higher than any other category. You go to specialists, the vacancy rate in some subspecialists is higher because the skills is a challenge. So one of the big reasons is that there's a skills shortage, and in those areas it's slightly bigger than the others. The other reason is that let's call it the gap between a post going vacant and it being filled. That process that we go through is always a ongoing process of one post vacant, and then we advertise, and then we must fill. So in many instances, there's also a delay in finding the right person to skill. And now you heard it earlier, we're looking for a midwife, but the midwife must be in Maritzburg. Now we have midwives in George, but there's no midwife in Maritzburg. And then we struggle to get it there. So it's also then a delay and a mismatch of where the post is advertised versus the supply in that area. So I hope that makes sense to you. It's a combination of the two things. So the one is scarce skills. The other one is there's enough people around, but they're not in the places where we're looking for them, as the two main reasons. That then brings us to your question on page 175. And if you look of the vacancy rates there, the lowest vacancy rate is actually pharmacists. So pharmacists is the one category where we have more people wanting a job than what we can accommodate. And it's always been like that. Well, I mean, we produce quite a lot of pharmacists in our system and pharmacist assistants. So you will see a 3.7% vacancy rate. And you compare there to the one that I just spoke to you about industrial technicians. You can see what the vacancy rates for industrial technicians, because for technicians, there's a bigger shortage of 25% vacancy compared to pharmacists of 3.7. So the 3.7 is actually half the average of the 7% vacancy rate. And actually, it's mainly, this one is mainly about getting somebody in a place that's very remote. But generally, there is more pharmacists that want to work in our system, but it's just when you want the pharmacist to work in Maritzburg, it's also going to be a problem because that is that difficulty. So I hope that explains the two areas. And then just member classes. So it's a very interesting question that you pose, because one of our philosophies has always been somebody that presents to a hospital from a public health perspective. The person is assessed according to their need, and we provide the service to them. So that's so we present. And we do not want foreign nationals to feel that they targeted by not providing a service or providing barriers for them accessing care. But when you do assess the person, there needs to be a process for the person to be registered in our setting. So if you're not a South African, we normally ask all South Africans, what's your ID number? So we register all South Africans according to their ID. You're not a South African, we would say, okay, what's your passport? And do you have formal papers and do you have formal numbers? Now, in that case, if somebody cannot produce it, we do not deny access to service. But it is a process where we would want to encourage, because we actually do have a policy that for emergency care, we provide emergency care to everyone. If you have to have care beyond emergency care, which means you have to have surgery, you have to have some complicated procedures, we then need to know your country of origin, because we have a process where we can then claim that expenditure from your country of origin, because if that is the procedure we did. We had a very interesting case of somebody which we all went to visit in the Western Cape Rehab Center. That person was actually a Nigerian origin, but landed up in a very severe accident and was in our rehab center for 8 months. And eventually it was cheaper for us to get a staff member to put that person on a plane and fly that patient back to Nigeria, because that person would have stayed in occupied a bed in the rehab center for as long as possible. And it's obviously a person from a poor background. We phoned and we made contact with the family where he lives, and our staff member took him home. But it's a very important question. We don't deal with it insensitively. We deal from a point that we don't deny access, but we also have to follow through that there needs to be a process for recuperating of resources, because in a sense, our primary responsibility is to South African citizens. Yeah.
Thank you, Dr. Klute. Member Van Vogel, did you have a follow-up question? You covered, thank you. This is totally out of order, Doctor, but the foreign nationals, do they currently pay for the services? Because under the new NHI bill, they will not be treated, as far as I understand it, for free.
So the policy that we have, maybe Mr. K, can you just clarify our financial instruction? Because that's one of the questions we've also posed in terms of the NHI, but we have a finance instruction that speaks to this. Sam?
So it's all good and well having a finance instruction that says we will bill you as an H3, but recovering from a person who has nothing is a different conversation. So yes, we do bill, but we then do a means test on an individual, and if an individual is unable to pay, they are unable to pay. Trying to pursue it with the embassies has been a non-starter. And so ultimately the financial burden does sit, and that's one of the reasons why our departmental receivables and the impairments go up in the financial statements, because ultimately we aren't able to recover what we've billed. Thanks.
Thank you very much, Minister.
Also, even before we go to the foreign nationals, remember, even among us, there's the issue of the payment as per the income. So the ordinary anti-SARA might get free the same operation where I might be charged 100,000 for a 2-day ICU stay based on the income. So it mustn't be about that you charge only foreign nationals and then South Africans don't. For example, for me, I use public, but when I go to Provincial, I charge using my medical aid for some of those kind of things. So we need to understand that as per sliding scale in terms of the income, you get charged.
Thank you, Minister. Members, any more questions on part A, B, or D? Can we then adopt part A, B, and D, members? Member Fry?
Chair, move to adopt.
Thank you. Seconder?
Chair, I second it.
Thank you, Member Glass. Members, ladies and gentlemen, we've come to that part of the day where I have the pleasure of expressing my gratitude and thanks to all concerned. I'm not going to repeat what I said earlier about the quality of this and the quality of the work done by this department. It is good company to be in from a politician's point of view. So thank you very much, Minister, HOD, and the entire staff component for the excellent work you're doing, the dedicated work you're doing. In Afrikaans, there's an expression which I've heard when I was a young boy, and it says, "My heart is so blink so snoekvel." My heart is as shiny as snoek skin, if I might translate. So my heart is as blink so snoekvel for all the work you've done. So thank you very, very much on behalf of myself and the committee. Thank you very much. The committee will stay behind. Remember,
is there lunch?
There is lunch, but we were trying to save, but in your case, we will have lunch for you.
Thank you.
Lunch will be served, and you are more than welcome to join us there. We will just finish our proceedings here and see you later. Once again, thank you very much. Just that too. Members, thank you for that. Members, do we have any recommendations or resolutions or any further information that is to be requested that we need to attend to? Also, whether you have concerns about the findings? Sorry, your mic, please.
If we can get the total of hospitals on the, what do you call it,
Total of hospitals?
who are exempted from load shedding.
Oh,
Is
number
the
of
member-
hospitals exempted
member-
from load shedding. I think it's 10. 6. It used to be 6. I think somewhere
Not 10.
I think somewhere it says it used to be 6. I think it says somewhere in here it's 10.
10, yeah.
Yeah. But you want
So those
confirmation of that?
hospitals, yeah.
Yeah. Confirmation of that. Anything else, members?
There's the discontinuation of activities. We need a correction. They said only George and Cape Town. Yeah, but when they are explaining, they talk about a lot of places that they've been stopped and then been assisted. That they make an example about Beaufort West. They said in Beaufort West they are moved to go and help that people. They are not just so they said that it's not only George and Cape Town. So there are other places, but we need them to specify, because we cannot keep a record of just being discussed by them and then it's continuing. Thank you.
Thank you, Member Klaas. Did you get that?
Is it the transport?
Transport. Thank you. Member Fry, was your hand up?
Yes, thank you, Chair. Just on mental health, for future plans, project 1, on page 11, the appointment of additional staff that can deliver mental health care services, and as well as training and equipment of psychologists and registered counselors for the rural and metro areas. Just a breakdown of how many staff are we going to apply for that project, and where the staff will be allocated to, so we know exactly where it's coming from. Thank you, Chair.
Thank you, Member Fry. Is it good? Members, anything else? The date of the meeting for the consideration and the adoption of the committee report will be communicated later. This meeting is adjourned. Let's have lunch. Yes, members, yeah, sorry, I have adjourned, but my apologies. If we can just, with your permission, can we add that the committee, I don't know when it's going to happen, pay an oversight visit to Planet Youth in George, the project that Dr. Klutu referred to that is so successful with the youngsters in the programs that they're rolling out about health and et cetera, et cetera. If that is what you want to do. Yeah, and then tomorrow morning we will leave at 12 o'clock and not 9 o'clock. Yes. Members, I'm happy. I'm very flexible. Can we leave at 1? We will leave at 1 tomorrow. Thank you. It's close enough to 1 o'clock, I think.